No, okay. Chair's opening comments. I'm just going to say one thing, and it resonates with what we've heard today from members of the public. 2 days ago, the British National Survey results came out. British National Survey results, a survey that happens every year, high-quality survey of England, and it's been happening for 50 years. And those survey results showed that for 2023, the public had the lowest confidence in the NHS it's ever had. And that resonates, I think, with some of the comments that we're hearing today. So we know that confidence of the public in the NHS is of critical importance to both in terms of people's feelings of quality of care, but also in terms of how our staff feel and how our staff are able to manage in this most challenging of times that they face to be able to deliver high quality of care. So our expectation and hope is that we see a reverse in those public satisfaction levels. And you'll hear in due course in these meetings how this organisation, the Integrated Care Board, which is NHS Cheshire and Merseyside, is leading a process called a 5-year joint forward plan that articulates some of the key priorities and how we think we can work with the public, patients, staff, trade unions and clinical leaders to improve the satisfaction of the public with the NHS. That's all I wanted to say. And I want to go into the resident story, which I think will be...
My name's Ruth Little. I live in the Everton area of Liverpool. I have 3 girls, and I'm here today to tell the story of one of my daughters, Jess, who unfortunately died of cervical cancer in 2016. Jess only lived around the corner from the centre where we worked, and I only lived up the road, so we saw each other on a daily basis. And I started to notice, because she complained she didn't feel well. She'd say, "Oh, Mum, I've got awful pains in my stomach. I don't feel a bit well." And I'd go, "Have you been to the doctors?" "No." She'd make an appointment and she'd go, and then she'd come back and go, "What do you say?" "Oh, doctor said I've got a water infection." And then a couple of weeks later, she went back and it was a kidney infection. And I said, "But if you've had a water infection, you've had tablets for the water infection, now you've got a kidney infection, something's not right. Have you asked for a smear?" So she went, "I did, and they told me I'm not due for one yet." So I went, "Right, okay." Twice in that time presented herself at the hospital, and both times she was neither examined nor given a smear test. She was just told, "Oh, it's a water infection, it's a kidney infection, it's an ovary infection, your ovaries are infected." So this went on for quite a bit, but she just started getting more and more tired, more and more weary. I said to her, "I'm taking you to see my doctor." So made an appointment for her for the 5th of January. So they brought the nurse in and they examined her. He said, "I'm a bit concerned with what I'm seeing." So they took her into a room, examined her, explained to her, "Sorry, Jess, it is cervical cancer." Jess presented herself at the hospital and at the doctor. She presented herself at the doctor's about 7 times. And she presented herself at the hospital 3 times. And I don't understand why nobody through them times gave her a smear or examined her. It's beyond me. So then we started then on the road to treatment. The treatment continued. Then it was a kidney. So a couple of times she ended up getting taken in for her kidneys because of kidney pain in her kidneys. When I got back, she was crying, and Jess never cried. And I said, "What's the matter?" And she had the consultants been in to see me, the kidney consultant. And I said, "Okay, so what's he said?" He said, "Well, he doesn't know why he was there because I'm riddled with the cancer. It's wrapped itself around all my organs, so I just need to be made comfortable and sent home." And that was the first time, really, we knew it was the end, because nobody's ever said anything. And then they asked, could she be transferred? They had a bed for her in Woodlands Hospice. She was starting to deteriorate. Her ears were going black. And the nurse was going, you know, you need to make sure that the final time is a time that suits the family. And then she just had a seizure one Monday, and everybody went home that night. We put music on and I lit candles and we just prayed and prayed. And then I just said to her, Jess, go home. Go home. Too much pain. In the blink of an eye, I'll be with you. And then about an hour later, she passed. And it was just such a peaceful passing. All things happen for a reason. I don't know what the reason is. It doesn't make sense to me. But what does make sense to me is that this was futile. This should never have happened. At some point, very early on in this, somebody should have done a smear. Somebody should have done an examination, and nobody did. So for just on 9 months, this cancer grew and grew and grew. So all our pain and all our family upset and everything that we've and other families go through may have been avoided for them as well, but it definitely could have been avoided for Jess. They could have done something sooner.
Okay, so let's move on. And thanks. And thanks. Listen. Can I just say we're now into the public meeting. If you continue to interrupt, I will have to ask you to leave. Okay, shall we move on? Let's move on to the Chief Exec's report.
Why did you show it? What was the point of showing that just to say you care? What was the point of that?
You only deserve a discussion.
So, let me just remind why we have the resident and patient stories at the beginning of our meetings. It's to try and bring the patient into the room. And we will see later on in the agenda, as we are talking about things like cancer and diagnostics, the relevant factors. It's to bring the patient into the room, and it's not respectful to the individual who's given her time and effort to be videoed to respond to this directly. That's the deal that we have with those members of the public. So, Chief Exec's report.
Thank you, Chair. This is really difficult. This is really difficult to reflect on that story that we've just heard. It's really difficult to reflect on where the NHS is at this point in time, and in particular, the fact that, Chair, you've highlighted the national opinion survey that shows that in the eyes of the public, the NHS has got the worst rating that it had since that survey began. I think it's fair to say the NHS is in a very difficult place. We were always really clear that the consequence of COVID would take many years for the NHS to recover from. One of the things that is also clear to me is the success of the NHS will always be intrinsically linked to the financial context that we work within as well. And the NHS has seen an unprecedented year of inflationary pressure. inflationary pressure that has crowded out almost everything else on the agenda. Now, we would all agree that seeing NHS staff paid more money is a good thing. But actually, it's the inflationary pressure in society. It's the fact that the fuel bills for every hospital that have gone up. It's the fact that the price of consumables that are used on a day-to-day has gone up. And just therefore coping with that standstill position has actually restricted our ability to develop and progress some of the things that we know that we can progress. And I think what our job to do is to find a way of separating out between those things for which there's an external context, those things where we wish that the government would invest more money in the NHS, and those things that are in our gift, those things that are in our gift to improve. And where I find this really difficult, and Chair, I think it's absolutely right that we heard Ruth's story. I think it's absolutely right that we have that salutary reminder that we don't always get this right. But we have to think not only of the individual patient, but we have to think of the whole body of patients and the patients who are yet to be patients that we serve. The other thing I wanted to say is therefore we have to be able to show people that we have the confidence and the mechanisms and the ability to continually and progressively improve. But even if we are progressively improving, getting the NHS back to the place where it was when many of us have worked before is going to take time. The other thing that I just wanted to say in context is the industrial action that has taken place through the last year has created another overlaying and difficult environment for us. The disruption that that's taken, and again, we've been really clear. We respect the rights of those staff to undertake that industrial action, but it destabilises the way the NHS works. But what I do want to say to you is, since that last period of industrial action, through the last month, we have seen a period of improvement. A period of improvement that still says to me that the services that are offered are not good enough. But throughout the last month, ambulance response times have improved. Now, one of the things that we've talked to you about here before is the deliberate nature to say the patient who is the least safe is the patient that the ambulance hasn't got to yet. Now, that means we've taken people into our hospitals sooner and we've transferred the backlog to somewhere else up the line. But ambulance response times have consistently improved through the last month, and in the Northwest, they are some of the best in the country. I absolutely take the points that's impassionately been made from the floor, and that the experience that people are having of our accident and emergency departments is not good enough. But actually, through the last month, our A&E performance has improved. We've reduced the longest waiting patients significantly since the last period of industrial action. And again, we have some of the best performance of that in the country. The reduction in the cancer backlog across our patch is again some of the fastest in the country, and it's why within the report that I've highlighted the diagnostic work and the endoscopy transformation work that is taking place. And something not within the report, but I'm reminded because Anne wrote to me in the last month about this, but some of the work that was set in train across this patch around the redesign of stroke care pathways is we now have the second best performance in the whole of the country against the published gold standards for patients who present to our hospitals with a stroke. And it's really difficult, isn't it, that we need to have the honest conversation about things aren't good enough, but we also need to give people that hope and vision for the future that it can be better, and we need to also use this board meeting to celebrate some of those successes and improvements. We will hear later that it's going to be another really, really difficult year for the NHS. Yeah? But it's our job to make sure that despite that, despite all of the distraction that creates, that we continue to see month on month improvement in the standards of access, quality and outcome that we can get for our patients. Now, just to put you on warning, Ian, I'm going to bring you in a second just to give an update on the measles outbreak that we've been trying to respond to. Now, there are also some things within my report, Chair, that I'm not going to talk about and feel that they are a little bit of a teaser or a trailer for substantive board items later on, particularly dental access and also the primary care improvement plan. But I did just want to highlight and ask the board to note the paragraphs about the Thirlwell inquiry. Now, we don't know what will happen until evidence starts to be given, but I can tell you we have fully cooperated within the inquiry. We submitted something like 75 items of evidence on behalf of predecessor organisations for which we are legally responsible. We have been fully cooperative to that, and at one level it is reassuring to say that the chair of the inquiry does not want to make us a core participant and does not believe we are likely to face significant or explicit criticism for the roles of any current ICB employee or the former CCGs. But really important that we've gone through that process and been open and transparent. If I can bring Ian in to talk about measles, please. Please.
Chair, could I just say something before Ian's brought in? Firstly, I want to apologise for having lost my temper early on and the way in. Just to put into context, on the train on the way in, I found out that I lost one of my Labour colleagues in Sefton, a young woman and mum as well. So difficult situation, but to then be told that I'm here to privatise and to support big business is completely insulting, and I lost my temper. But I apologise for doing that. And just to say that I've witnessed corridor care at Aintree Hospital, and it was absolutely awful. I felt so much for the people who were there, and I lose no opportunity in the committee in which I sit and in this ICB to raise the issues and concerns that we've heard today, but to pledge the commitment of local government to work in an integrated way, working together. That's what integration is about. Integration of health services and of local government as well, to try and do the best, given the absolutely awful circumstances that we're in and the challenges that this government has brought us to now. But I know the commitment of everybody around this room to try and make things better, and we will. And we will carry on trying to do that with every sincere effort. Nothing about privatisation or supporting big business. It's about people. And that story, as awful as it was about a person and a family who suffered. And we've got to get things better in every way, and people here are committed to do that. And I've got to say, from local government, we want to support the improvement of the NHS in any way we can as well.
Thanks, Paul.
And it's about integration
Ian?
of budgets, not services. And it depends on how you
Ian,
do
carry on.
privatisation or improvement.
Just with regards to moving on from the measles and question and the references in the report where there's a bit more information, and the building on us working as an integrated care system. We still have sporadic cases happening across Cheshire and Merseyside and the North West, so it's really important we're driving forward the measles, mumps, rubella uptake vaccination programme, and we're doing that collectively together. So working across all 9 of our areas and with our providers. So, for example, the majority of our trusts have 90% uptake rates within their staff. Where they haven't, they're prioritising that work as well and working with their occupational health teams. We are working with our regional colleagues where we've got community pharmacies now supporting schools and increasing access into that area. Our GPs and primary care are doing national call and recall programmes, and you would have seen the childhood immunisation campaign that was actually shaped by our colleagues in Liverpool and the North West here, and that's seen the increases that we, or help contribute to increasing the demand for MMR uptake as well. It's really important that we get that prevention message in place, and all of our 9 areas are doing a lot with our school-age immunisation services, our trusts, primary care, and our Live Well bus going out to schools and within communities, and working with businesses to promote that as well. So I'll leave that there, Chair, and welcome any questions.
Thank you. Any questions on the Chief Exec's report? Are you all comfortable? Ruth?
Thank you. Just to say, it was really pleasing to see how much effort is going into the measles campaign, and to congratulate the teams that are working so hard on it. And just to underline the point that this is really important up to about the age of 25, because the original drop in MMR uptake is now about 26 years ago. So we must make sure that young adults, students, colleges, universities and workplaces, and I'm really pleased to hear that the NHS is also looking at people who may have missed MMR because of the changes that happened many years ago. So really pleased about that. I have a question. I'm really pleased to see that we have the Healthcare Partnership draft strategy. I think it's absolutely crucial. And listening to the conversation we've just had this morning, the importance of attending to prevention, supporting people in the community really has got to be a strong part of how we change our urgent care pathway. So my question was, it's a really good broad approach. How will we know as a board, looking at the role of the NHS in that partnership, what can we hold the NHS to account for playing its part in that partnership programme? Are we going to see, as the draft strategy develops, some clear measures that the board can say, yes, we are playing our full part? The only one I can see at the moment is a 1% shift of spending into prevention, but it doesn't specify if that's NHS or the partnership as a whole. But I'd like to see also what actual outcomes are we asking the NHS to contribute to as that draft strategy develops. I realise it's draft at the moment, but I think that's really important so we as a board can be sure we're doing our bit.
So I'm Vice Chair of Healthcare Partnership. There most certainly are a set of metrics associated with the plan. Ian, do you want to give us some view on the metrics?
Yeah, so we're trying to work through, we had, you remember we talked about the Altogether Fairer report, so there's a number of beacon indicators that we look at as a system, and each of our 9 areas working with the health and wellbeing boards, there's a golden thread through there. So for example, there was an article just this week in the BMJ referencing that golden thread and the work that we're doing as a system to tackle inequalities and make some of that difference. We're keen to put in place some of those metrics around oral health, for example, just to choose one around children's well-being and how we can prevent dental caries and dental admissions that we know are one of the biggest reasons for under 10s, and there's a range of other things such as healthy life expectancy that we would be contributing to. So probably worthwhile having a more detailed look into those metrics as a board, if that's helpful.
And what you've recognised, I think, in that, Ruth, is they're high level and we need to apportion accountability to the different types of organisations. That's absolutely on our agenda.
That's my point. Thank you very much.
Let me bring in Graham.
Thank you, Chair. I think the other thing that is kind of quite difficult in this place is I am trying to differentiate really clearly between those things that are primary prevention and those things that are secondary prevention. And those things that are around secondary prevention, we have loads of really near-term, close-term measures. You know, we can measure the number of people whose diabetes is under control. We can measure the impact that we are having on the rates of falls and things like that. All things that do contribute to life expectancy. But in the Altogether Fairer piece, we are trying to take that ring-fenced pot of money that not only will we invest in this year, but we will increase in future years, is an attempt to make sure that delivering today does not crowd out everything for the future. But we are talking about investing in things that have very long-term, intergenerational payback, so we are more likely to measure that and be held to account on what I would describe as input measures, not outcome measures.
Thanks, Graham. Rowan?
Thanks, Ruth. And we'll hear a bit more today with the Data into Action paper, that absolutely we must gather the highest quality evidence and then make really good decisions about how to respond to the problem out there. Bring the right actions forward, and they must be done in partnership. A lot of this is not purely NHS stuff. Colleagues will know from the clinical constitution, I am really clear. We've got to get better at managing wellness rather than always responding to sickness. And I think that the really high quality health intelligence will also be social intelligence ultimately, that feeds all the way through to our healthcare partners, because getting housing right makes a huge difference to health long term. And we need to be sharing that evidence all the way through with our partners so that the best decisions are made that feed through to the best health possible. So that's going to be an ongoing part of that programme as well. Thank you.
Thanks, Rowan. And from my perspective, you can see a movement happening in NHS organisations that previously would have thought that working both in partnership but primarily in prevention wasn't any of their business. And just recently, NHS providers have published a really good toolkit that helps NHS Trust boards think through what their role is in that place. So you can see momentum going, but we're not there yet. Okay, so can we move on? Chris, Director of Nursing Report.
Thank you, Chairman. So the report provides an update on the work of the local maternity and neonatal system within Cheshire and Merseyside, which is responsible for the delivery, oversight and assurance of the National 3-Year Plan for Maternity and Neonatal Services. And you'll see there within the report the 4 identified themes within the 3-year plan. So the LMNS works with all of the 9 places within Cheshire and Merseyside to ensure that they deliver on the above responsibilities. And the board will be aware that I've previously mentioned around the National CQC inspection for maternity providers has now been completed. And you'll see under 5.3 the table there that provides an update of the reports for all the Cheshire and Merseyside maternity providers and their ratings following inspection. You'll note that there are 3 reports that are still outstanding, and they are currently in the factual accuracy stage, and they will be published within the next few weeks. You'll see that there are some identified themes that have come out from the reports that have been published. And once we're in receipt of all of the provider reports, there will be a deeper dive into the themes, and that will be scheduled, and we will feed that back through into the Quality and Performance Committee. And the report also highlights the CQC Women's Survey that was published for 2023, and that was published in February, and you'll see from the narrative that the providers show signs of improvement in many areas. The LMNS works with the providers to support delivery on all aspects of the priorities and themes within that 3-year delivery plan, and it also provides assurance of compliance with the Maternity Incentive Scheme Year 5, and the table on page 22 shows the 10 safety actions, and I do have to share with the board that all providers have declared full compliance with submissions which have been approved by each of the provider boards and subsequently signed off by our ICB Chief Executive, these were submitted on the 1st of February 24. The report goes on to highlight the work of the Children and Young People Board, and within the report it shares about the Beyond programme that continues to support the Health Equity Collaborative, which is between Barnardo's and the Institute for Health Equity. And we are one of 3 ICBs as part of that pilot. We've now recruited 4 young people to act as the health equity champions, and they're working alongside the Beyond programme and have recently shared their view with the ICB Children's Committee. The next steps then will include identification of pilot interventions to address some of the drivers of health inequalities, and based upon data indication set and focus on the population most at need. Our Beyond programme have identified as the delivery partner for a 3-year supervised toothbrushing programme, and recruitment's commenced for the programme delivery roles. The report also discusses the work that they're doing to reduce the rates of asthma and respiratory illness, and it mentions the numbers of families which have been identified and supported across a number of our places. And finally, I just wanted to bring to the board's attention that in May we will celebrate both the International Day of the Nurse and International Day of the Midwife. On the midwife is 5th of May and International Day of the Nurse is 12th. And the theme for 2024 is the economic power of care, and this was chosen to highlight the need for nursing to be seen as an investment. Within the ICB, we're going to be holding an event for our Director of Nursing colleagues, chief nurses across the system, along with our associate directors within place. I've invited our Chief Nursing Officer, Ruth May, who will join us virtually on that day to celebrate. And I'm really looking forward to celebrating with nurses and colleagues across the system. So I'm happy to take any questions, Chairman.
Thanks, Chris. Good to hear about that celebration. Any questions or comments, Chris? Tony?
Yeah, thanks, Chair. I'd just like to echo Chris's comments about maternity and the receipt of the CQC reports, and the idea that we're going to examine key themes. I think just for the board's assurance that we've been developing these themes throughout the time and receiving reports from the LMNS. So we've got a very good sound grounding of the state of maternal care. I just ask that we do include the results of the survey that Chris mentioned at 5.5, because it's important not just to look at the performance of services, but also the impact it has and the experience of those receiving care. So I look forward to bringing that back to the board.
Thanks, Tony. Ruth?
Thank you. It's on the survey I wanted to pick up. It's good to see that 5 of 7 trusts are showing some improvement, and obviously I'm sure you'll be working with the 2 that haven't been able to progress. My question was with regard to equality, diversity and inclusion, the danger of looking at averages and responses that we miss key areas that need attention. So I just wondered whether you were able to look at the data from that perspective to make sure that we are targeting the actions that we take forward.
So in response to that, I mean, Hilary might want to come in as well as chair of the LMNS Assurance Board, but we're currently working on building the data set with our business intelligence team around looking at the health inequalities and how we measure across the system and also compare across the rest of the region and nationally. And so...
Sorry, does this CQC survey enable you to look at the patient responses by EDI considerations? That's my question.
And if we dive down into detail, I don't think it hasn't given me that level of assurance yet, Ruth. No, sorry.
Did you want to say something on that point, or?
Sorry, yeah, I mean, the LMNS has been challenged by us to look at diversity, particularly within maternal mortality, neonatal deaths and maternal injuries, and they're working really hard to get that information. It's not available at a regional level at the minute, but we're working with providers to get that and to get an aggregate view. And once we do that, I've spoken to Anthony about getting those senatorial metrics on our performance report. Thank you.
Erica.
Thanks, Chris. My question is regarding the subject we discussed back in Macclesfield, and that was CHC. And my question really is, when we understand where the review is at, my knowledge so far is you told us it was under review. It's been mentioned in continuous improvement paper that we're looking at later. So when will we be informed of progress?
So the review is in progress. We are due to, on the 1st of April, which is Monday, transfer 120 staff from both Merseyside and Midlands and Lancs CSU, the Clinical Support Unit, as part of the review. And once the staff transfer across, we'll again begin the management change with our current staff. The review is continuing. Clearly, there's a huge amount of work to do there. And so there's an implementation programme plan, and we aim to have the review completed with all staff transferred across, management change completed by the summer of this year.
That's great, because there's the quality piece of it and getting the right service for our residents, and there's also the money element that we'll start to talk about again in month 11, I'm sure. Thank you.
And that does feature in all parts of the review.
Thank you, Chris. It was really good to see the work around intent, around working with the schools in helping tackling smoking and the vaping challenges. And I suppose it was just to make the board aware of altogether smoke-free ambitions. We had a sector-led improvement workshop with all 9 of our local authorities, all our treat and tobacco dependency trust programmes earlier last month, trying to bring that together about tackling tobacco and the role of vaping within that. So the fact that this is having that reach into our schools, I think, is really important, and it links into some of the inequalities agenda around NHS Core 20+5 as well. So to make that aware of the ICB acting as a system within that.
Good point. Further questions? Chris, just a comment and an ask from me, just to build on Ruth's question about EDI and the protected characteristics. I would like to see a report coming back to this board via the Quality Committee on the progress or what the assurances that we have around the access and outcomes for marginalised communities. And given that we've had Embrace around for years and so on and so forth, it shouldn't be new. I think we should be already into the improvement cycle. So perhaps if we could see that at next board. And of course the really important issue about CHC. And is that next board, or is that when would you want to bring up this is the current state of the progress of the CHC review back to this board?
We could provide an update in the next board. The review won't be completed at the end of May, but we can give a significant update.
Thank you.
Yes, thank you. So the report that you have sets out the financial position for our system to the end of February. When I've reported here in the past, we have briefed the board on a risk to the financial performance of the system of up to 40 million, as it was last month when I reported last, with an additional £20 million worth of risk associated with ongoing industrial action. Since then, we have now had confirmed funding in relation to industrial action, but we've also had an additional month of costs. So whilst we have improved our position excluding industrial action to a risk of 30 million from previously 40 million, the confirmed allocation that we have had on industrial action now means that some of the costs associated with that will now be reflected as an overspend in our position. So there's a pressure of 20 million pounds associated with that in these current forecasts. So this month we formally adjusted our forecast with NHS England to give us a deficit of 50 million as a system by the end of the year. That is still being worked on. Over the course of March, we are still looking to see where we might be able to mitigate and pull back some of that. But you'll know from previous conversations that the formal forecast could only be changed this month for the first time. So that is something I'm asking the board to note today, or to approve today. what I would draw your attention to is the graph on in section 2.8, which shows the plan that we, and this is a graph you'll have obviously seen before, and we update it each month, but the departure of the way that we've delivered our plan from a recurrent position to from a non-recurrent, using non-recurrent measures, is quite stark. So whilst we have we are away from plan in our forecast this year, we've done that with a lot of non-recurrent measures. So the underlying financial position, you can see in the graph there, is significantly lower than the position that we're reporting formally. So that is something that we will need to address in the new financial year, and will be subject to conversations as we discuss our planning processes over the coming weeks. So I'm going to pause there. I think one of the points probably just to mention before I do actually is the consequences of the position that I'm reporting today. So there is a repayment process in the NHS that will mean that any deficit that we do finally end up reporting this year will need to be repaid in a couple of years' time at a sort of there's a certain percentage that we need to repay over a number of years. We do have brought forward surpluses from CCGs of about 20 million that will offset the majority of the ICB's own deficit, but there will still be a residual there. So that will be something when we've worked through the detail of the repayment processes, we'll bring back to a future meeting so that we can all be really clear. And I'll pause there for questions. Thanks, Chair.
Thanks, Claire. Any questions for Claire? So Claire, just a comment for me to help me understand the deterioration from the beginning of this year to the approval that you're asking for, about £50 million deficit. Just give me some headlines about why we've seen that deterioration this year.
Sure. So in the ICB, the key drivers for that are the overspends that we've been seeing and pressures associated with continuing healthcare and mental health packages of care. And they are together, they account for £60 million forecast by the end of the year. Around about half of that has been influenced through prices for care packages that have significantly exceeded the levels of inflation that we've had funded for, and the other half is predominantly around the levels of significantly increased demand over the year as well. Prescribing is also an area that we've seen pressures on inflation particularly, but we've seen some mitigation of that over the last couple of months as our QUIP programmes have played in. So, but it's continuing healthcare and mental health packages of care in the ICB that is the single biggest factor influencing that overspend. Part of that we've mitigated through holding investment or having slippage in programme budgets, but that is an underlying position that is something we need to tackle urgently. And on the provider side, a big chunk of that is the impact of industrial action, which hasn't been fully funded, but also a number of other pressures that providers are experiencing, particularly around urgent care. And we talked about the pressures in ED earlier across our system. So not only are pressures in ED awful for patients, awful for staff, they're also, it's providing care in a way that isn't the best value as well. So there's a financial consequence to that too. So they would make up the key variables in the overspend that we're reporting today.
Thanks, Claire. So it emphasises, I think, for the ICB, the budget control that it has, the work around CHCs.
Yes, absolutely.
Okay, that's important to note, I think. Any other questions?
Hi, Raj. Can you hear me? I'm sorry.
We can, Neil.
Yeah. Apologies, I'm not there in person, but I am in the meeting. I can see you all. I can hear the debate. You can take part. Just in support of the statement from Claire, it's a remarkable position we find ourselves in because of the extreme circumstances this year around inflation, strikes, and other operating cost pressures. And I think in a normal environment, if it hadn't been for the inflation and the strikes, we'd have been close or thereabouts. And I think what Claire's presented, I think credit to her and the team and the network, is that there's no surprises in this. We've been alerted to these risks throughout the year. We've been fully cited on them. I think everybody's done everything as much as possible to mitigate the circumstance. So I think the outcome is not where we want to be, but it's as good as it can be. And I think the important thing is going forward is to look at those operation areas we need to improve. Hopefully there'll be more stability around inflation and workforce and strike issues, so that going forward we can capture this and come up with a positive plan going forward. But I think there's no surprises in what Claire's reported. I think we've all been fully cited on these. And I think she has worked really hard with everybody to mitigate and get us in this position. So well done.
Thanks, Neil. Useful comments, but we'll just, I said, just make this comment to what you've just said. Absolutely everybody's been working really, really hard. But we did set out a plan around CHC at the beginning of the year that we expected to yield a result, and that's within our control. So I think the board's focus on that, given the significant nature of the scale of the deficit on that, I would just like to add that back into your comment, Neil.
Yeah, I think that's the point we was making going forward. There are operational areas like continuing healthcare, prescribing, where we know we've got real issues and challenges going forward, and they're things we can and must take control of. The other external issues that have hit us have been quite unprecedented. So if we can look at our forward plan and focus on the key areas, I'm quite optimistic going forward that we can hopefully turn this round.
Okay, thank you. Claire, do you want to carry on? Is there oh, sorry, Sarah.
Not sure if I've got this working yet. It's just the concern about the knock-on effect in future years. We all know the scale of pressures that our services are experiencing and how difficult it is to make any further savings. And all the things that we want to do to try and move to prevention all carry a cost. And it's just the impact of having to struggle with all of these budget pressures on top of all the service improvements and changes that we want to make a real difference, and just sort of some sense check of how that's going to affect plans for next year. I know it's probably too early to say in any detail.
So, we probably should have more detail on the next year's plans, given we're very close to the start of the new financial year, but it is an unprecedented time, and we've still got a lot of work to do, so we are still working on them. But you're right to raise it. It will have, we are looking into next year and seeing some really big financial challenges that we're going to need to address. We still need to develop fully the plans that will get us there. I think that there are so many areas that we know will have an impact on improving the care for patients, as well as improving the value of what we're doing. So, corridor care, having patients in hospital that don't need to be there, all of those things have a cost, which when we put our absolute energies behind and make the improvements we need, will also benefit the financial position as well. So there is a lot of in there that will improve both financial position and the experience and care that patients receive. But you're right, there will be some difficult decisions for us to make as well in the short term as we work through those plans.
Thank you. So Claire, do you want to carry on with the rest of your report? Just carry on, Claire.
Okay. So the final point I'd like is just to, if there's no more questions, happy to take any further questions, but I'm asking the board to approve the revised financial forecast for the year, and noting the position on the provider positions set out in the paper.
Okay. Anne?
Just to comment on the difference between the run rates. Quite clearly, although inflation can come down, it doesn't reverse, so you don't get that year of inflation followed by a year of deflation. You just get the inflation baked in. So obviously the fact that that run rate has improved so much is because of non-recurrent things. One would have hoped that the industrial action was a one-off cost in the run rate this year, but clearly there will be
further episodes in all likelihood.
Yep.
So, you know, we are, although this is a really good position to get to, not complaining about that at all, it is just masking, I think, you know, an underlying deficit that's been, you know, able to be managed one-off.
Yep.
But it's not like the inflation's gone away, it's still there, and it'll still be in the prices we pay. The prices don't go back down again.
Yep.
In a situation like this, they stay where they are, and so we've still got that, you know, there's quite a big figure there, and as you say, we haven't got a plan right now to find a way to solve the financial problems associated with some of the overheating in the urgent care system. So I'm kind of sympathising with the task of, you know, there's this position, I'm sort of kind of saying to the board, this position is really good, but it is kind of masking some really difficult problems as we go into next year, next week.
It really is, yeah, absolutely agree.
Okay. Can I seek the board's approval for the financial?
Sorry, just quickly, I think it cannot be overstated that the challenges we face financially ultimately feed through to outcomes for patients. And the clinical role alongside our financial colleagues and others is absolutely vital.
Yep.
That we are protecting care. And ideally, as has already been touched on, if we get patients off corridors, which is awful for patients, their outcomes and the finances, that's got to be the right place for us to be getting to. And that the commitment of all the clinicians across the system is to play their part, to spend our money wisely, follow the evidence, provide care that it absolutely adds value, and not be pursuing care that is not in patients' best interest. That whether we like it or not is something that can end up going on out there, particularly around medicines optimisation, for example. So I do want the board to be clearly cited that the challenges that we face that happen to be financial are being managed with a very strong clinical focus at every step, which is what colleagues would expect of us. Thanks.
Thanks, Ryan. Erica and then Joe.
I do. I want to start probably with the understatement of the year of saying it is an extremely challenging financial year, which also, like we've talked about and Health Watch also mentioned, has impacts for next year as well. What I wanted to do is just provide reassurance to this board of what the Finance Committee has been doing. So first of all, I think the most important thing that we do is we robustly check that the systems and processes are in place for to provide that accurate information and that timely information that Claire has just walked us through on month 11. The second thing, it's also our role to scrutinise those budgets and ensure effective in-year management. So the budgets and the deep dives that we've done so far have been on CHC, and that's kind of started the ball rolling with the full review. It really is going to be a transformation of that service. The second one has been around prescribing, the impacts of inflation, and the mitigations that you've talked about in the medicine management pieces. And we've also gone through recovery plans both in providers and at place. The most recent one was Cheshire East, where we got into things like their deliverables, how much they could influence, and also the progress that they were making with collaborations. Having said that, we did raise the risk of P7 within the Finance Committee, which was currently at 16, so 4 for likelihood, 4 for impact. That has gone to 5 and 5. And we've also asked for a review of our own workforce risk as well, because the financial implications on that as well. That's it, thank you.
Thanks, Erica. Joe?
Thanks. And I mean, just to reiterate how appreciative we are of all of the really hard work that goes on to get to this place in the most difficult of times. But I suppose I'm conscious that last year we sort of said the same thing. And, you know, over many years, we keep saying the same thing, that we've got to reach for some set of different conclusions to create a different pattern of spend that gets to the reproducible outcomes that Rowan has talked about. So I'm just, it's asking a question, not really getting an answer now, but asking a question about what assurances are we going to undertake that the actions will be robust as opposed to magical. And I'll just say, as an organisation that runs CHC right now, I mean, I caution that you're going to do anything remarkable with it. It's incredibly difficult. So we have to be realistic in the projections we put forward around these things. And Claire, I suppose the real question for you, you've got your 4-pillar programme, which I really like, but getting to that 4th pillar becomes really hard when you're in this position. And I think we need some assurances around the board that we're going to help Claire get to the 4th pillar, because that's the place that's going to build all of the things that everybody in the room is either talking about or thinking about right now, so that we're not in this position next financial year.
Thanks, Joe. They're really, really important points and well said. I think we should pause on that rather than react to that. I am going to go to seeking the board's approval for the financial plan. Yep. Yep, as financial paper, should I say, not the plan that's presented in front of us, and the revised outturn for this financial year. And rest assured, we will have long conversations about the 4th pillar in terms of making sure that ourselves, in terms of the ICB, the wider system and our partners are doing the best we can with public money for the long term as opposed to short-term expediencies. Anthony, can I go to performance report, please?
You can, thanks, Chairman. So the paper is well understood and is a good signpost to a number of questions. I will pick up on a few elements of delivery. And firstly, and quite rightly, the largest problem, as we've discussed earlier today, is that of urgent care. You can see the position in terms of the key urgent care metrics up to the end of February to bring you up to speed on where we currently sit. We have seen an improvement in terms of our A&E performance, which is seen as the key barometer of urgent care performance. The objective set for this year was a 76% attainment of that standard. Next year's objective, we now know, is going to be a 78%, so that's part of a staged recovery back to the delivery that was seen a number of years ago pre-pandemic. In terms of where we sit right now, the first few weeks of March, we delivered 70% against that standard. And since last Friday, we've been holding what we've called a super-made event. So members of the board will remember previous initiatives such as Perfect Week, where an entire system puts its highest priority focus and resources to try and deliver and understand urgent care challenges by giving it its best effort absolutely round the clock, 7 days a week. That often comes at the expense of other focuses during that period, but it's not necessarily about turning the dial for that individual period. It's about taking the learning from that as to what is the most tangible interventions that were seen during that period. That's been operating across Cheshire and Mersey since last Friday, as I say. We're the first ICB in the country that's tried to do it across the whole of an ICB footprint, and that has realised some additional benefits in terms of that 4-hour performance. We've seen performance at 73% for the past 6 days. But I think coming back to a point that Graham raised early on, we have consistently said through the peak of winter and where we are now, that the unknown patient is the priority, and that's measured by how fast our ambulances can get to that patient that's calls 999. As you can see in February, the average response time for a Category 2 call was 43 minutes. We are expecting to land that very close to 30 minutes by the time March is finished. Indeed, when we look across the whole of the national position, we now believe the North West will be the only ambulance service that's been able to deliver that Category 2 response time of 30 minutes in the entire country. Most systems are much more challenged in that respect. I would stress that the focus of the super-made has been one of inclusivity. It's physical as well as mental health, and Joe's team in particular have played into how that's being managed. The output of this, there will be a formal set of debriefs which will match our winter debriefs, as well as our discussions that are in train about exactly what a true delivery model would look like for an urgent care improvement plan. And we'll fetch some of that back to board in due course. In terms of elective planned care, we now expect that by the end of this month that we will probably be in the region of only 30 patients that will have experienced wait times in excess of 78 weeks. All those patients are deemed clinically complex. Whilst there are a number of other patients, about 60 patients who also have waited longer, that is at their choice. They have chosen to defer treatment dates to later in the year. The challenge ahead for us is that we have around about 3,500 patients who have now waited 65 weeks. And the challenge is to eliminate waits of that length by September. I say that in the context of what we now believe is over 130,000 patient activities, procedures and definitive outpatient sessions that have been affected by industrial action during the course of this year. But overall, despite the impact of that, the Cheshire and Mersey system has delivered more planned care activities during 23-24 than it did in the previous year. In terms of cancer, I think that is something that we should recognise in terms of how things have improved. The current number of patients on an active cancer waiting list right now on a cancer pathway is now 20% lower than what it was pre-pandemic. We were one of the first systems in the country to get that level down to pre-pandemic levels, and since January, therefore, our treatment times have been reducing. We have a particular focus on how fast patients are diagnosed, and the standard is that we expect to get 75% of patients referred diagnosed within 28 days. We are on track for delivering that in March as part of a staged approach to a higher level next year. And one thing that we see very clearly within our overall pathway is that whilst for a couple of months we've not been quite at that level, our actual diagnostic to treatment times are very, very good comparably, and therefore we are have a high degree of confidence of delivering the standard overall. Again, all of those three elements I've talked about in terms of UEC, elective and cancer is all part of a longer term recovery plan since the impact of pandemics, which is part of a national trajectory. So I'll hold there if it's okay, Chair, and open up to questions from the board.
Thank you, Anthony. Paul?
Thanks, Chair. Just wanted to refer to the mental health figures that we've got. We heard in the finance paper about the challenges caused through increased costs through mental health care packages, and I think the figures we have here are quite interesting in that access to community mental health services seem to be doing very well. We're doing not too badly on early intervention and psychosis, but the talking therapies service, the figures there seem to be taking a hit. Now, anecdotally, I'm hearing that there are still people being referred to the talking therapies service that actually are in need of greater levels of help and support. And that concerns me that this figure may not actually represent the true level of trauma that's out there and the lack of help that people are getting. And just to comment on the dementia diagnosis rate, I've commented before that I think the national target of 66.7 isn't good enough. That means a third of people with dementia don't have a diagnosis. I think that's far too high. But concerned that our figures are staying static, and to ask what we're doing to try and improve dementia diagnosis, particularly in light, and as at the last meeting that Rowan talked about some of the new treatments that are coming in, and the fact that this could actually help people and put less pressure on the system at a later stage if we get that intervention right at that earlier stage and get dementia diagnosis done early. Thank you.
Thanks, Paul. So 2 questions, I think, in there, Paul. Joe, do you want to give a view about talking therapies?
Yeah, I think Paul's right that talking therapies tend to have more people, proportionally more people referred into them who probably need something beyond talking therapies. these are services that are very sensitive to fluctuation in the numbers of people seeking support, which is directly tends to relate to socioeconomic conditions, which tend to drive people's behavioural or anxiety and depression issues and so on. So I think it's right to ask the question about who's coming in and who should be triaged off into a slightly different service. I think too, we're doing a lot of work on digital access to talking therapies, which allows us to, at least to then differentiate the streams. I mean, that's very popular with younger people seeking talking therapies, not necessarily with the whole population. So it's a piece of work that's actively undertaken to assess better, A, the demand, and B, can we differentiate the channels into those services. But it does need to be higher than it is, and it's dropped significantly in the last 6 months.
Okay, and so there's an active piece of work going on, Joe, and we bring that back. Can anybody make a comment on dementia? Fiona?
Thank you, Chair. I can confirm that dementia diagnosis rates is something that the mental health programmes of the Cheshire and Merseyside mental health programme and our clinical leads within that have been looking at and considering. We do anticipate that the new drug treatments for dementia are going to get their licence in the spring, early summer. That they will then still need to go through the NICE accreditation technical appraisal process. We would anticipate that potentially dementia presentations will increase. Anecdotally, patients will not present with symptoms of early cognitive impairment because there is a perception that there is nothing that can be done about it. Appreciate though that social support etc. can be offered at that stage, but when there's a public campaign, which I'm sure our dementia charities are, well, I know they are ready to launch, talking about new therapies specifically for early Alzheimer's, I think we'll see our dementia diagnosis rates increase, but that is going to be a challenge. Delivering that service is going to be a huge challenge for all ICBs because it's not a simple, straightforward drug. It has a lot of complications and it's a very intensive regime that patients have to sign up to benefit from that drug.
Thanks, Fiona. And on the general point about dementia diagnosis as opposed to the drug, Paul was making the point, wasn't he, that our ambition is too low. Any comment you can make on that?
So the national target is obviously what we're set to. We can always set ourselves a stretch target for Cheshire and Merseyside. I have made a note to ask the mental health programme team to provide us with a specific update on what they are actually doing, rather than me just telling you they are working on it, so we can bring that back next time.
Thank you. Ruth, and then Sarah.
Separate question. Healthcare acquired infection. Thank you. You've changed the way the data are reported from previous board reports, which now gives us the actual numbers. It's to note that C. diff were about the middle of the pack, and E. coli were pretty much at the worst end of ICB performance on that measure. Just a reminder, this is avoidable harm. And probably linked to the conversations we're having about urgent care pressures generally and the pressure on systems. So I think it was the January meeting we were told that there was a review of all the improvement plans. And I guess I'd like to know whether, having reviewed the improvement plans, whether we think we can make some inroads into this level of healthcare acquired harm. Thank you.
Chris.
Thanks, Ruth. In regards, we've completed a review on the governance process around HCAIs, and I can update on that. And just wanted to share with you that we monitor the performance through the quality schedules with through that 9 places, our organisations, and we held a workshop last month regarding C. difficile toxin and what we're doing with within the 9 places. And what we're going to do is, through the Quality and Performance Committee, we presented to the Quality and Performance Committee last month, and we're going to do a deeper dive into the HCAIs, particularly around C. difficile toxin and also E. coli. And I think you're right to note about the correction in the way in the data is presented, because I think where we've got organisations that have got no trajectory in respect of those 2 HCAIs, it can sometimes reflect in the figures. So I think that's the review that's taken place, and I'd be happy to share that with you.
And if I could just add something before I bring Sarah in, could we look across all points of delivery? Because clearly the focus is normally on the acute sector, but the community sector, and I don't know what happens in primary care.
So we would focus through our place-based teams on all aspects of HCAI. Obviously, there are post-infection review processes where panels, we would determine the source of where the infection, particularly in these areas, the recordable ones, where they commence, whether it was community-acquired or hospital-acquired. So it's not just a focus on acute providers, it is on community and primary care as well.
Thank you. Sarah?
Yeah, comments on a few of the elements in there. Firstly, on mental health, completely agree with what the 2 previous speakers have said. We are also hearing experiences of people who their needs are becoming more serious. They maybe don't fit, they might easily fit into the programme for talking therapies, but they don't meet the criteria for secondary care, mental health services, and the impact of that is being felt not only by the patients themselves, but on their families, their informal carers, and also on community organisations who are sometimes trying to pick up the pieces when people don't really fit into the models that the NHS readily has on offer for them. On dementia, I'm a member of the core group of the Liverpool Dementia Action Alliance, and definitely there's a lot of interest in this subject. I would say that our statistics sometimes hide things. We know there are different barriers for different communities. And for example, the Chinese community, there's a lot of work being done by a local Chinese organisation to try and raise awareness with translated materials, because if we just expect people to come to us when they experience symptoms of early memory loss and cognitive issues, it's not always going to happen. And as Fiona said, if you don't think that something can be done and you just see it as part of ageing, there's a reluctance to come forward for something. And I know that people have experienced in the past, recent periods, while services have been recovering, waiting times for waiting for a diagnosis and a kind of a reassessment sometimes as the situation gets worse. It's really stressful for families. So if we need to be ready, if people do start coming forward more reporting symptoms, to actually respond to that, because just keeping people waiting for longer for an answer doesn't really help. Diagnostics, it's lovely to see something that's a success. I know how terribly stressful it is for people when they're waiting for a diagnosis, especially around cancer. And if you can rule out cancer as early as possible, then that's a huge relief to people. But I can't not mention the pressures. I mean, there are so many indicators where we're struggling for such a long period of time. And obviously you hear from patients about the impact on them, but more and more I'm hearing from staff about the impact on them of having to go into work repeatedly, not being able to deliver the care that they want to. That sense of letting people down, and what was more painful when somebody reported recently that's how that feels to be in that situation day after day, and they said, actually I've gone numb, and that's the most painful thing, because they can't allow in and still go back into work the next day. The impact of patients and families who are more stressed and more frustrated, and knowing that they haven't got an immediate answer and they can't deliver the quality that they need. So it's just a reminder that all of these numbers hide really human experiences, both for staff and patients. Final point, I know we're going to come on to dentistry later, but I think we need to look at a wider dental indicator, because that indicator there just shows how we deliver on the UDAs we've contracted, which doesn't tell us anything about people's experience of being able to get or not get a dentist. So if we hopefully agree the dental recovery plan, we need to look at more how we evidence the impact of that.
I just want to make a quick comment on that before bringing Naomi in.
Thank you. I mean, we'll talk about it in quite a lot of detail in a bit, but as part of the improvement plan, there will be a whole set of metrics, both in terms of activity, but more importantly, outcomes and patient experience. And clearly, we have an improvement board, and I think the Health Watch is already on that. So we'll be using your experience and expertise to build up those metrics.
Thanks, Claire. No, just, Anthony, did you want to make a comment on what Sarah's just said, or was it a different comment? Otherwise, I'll bring in now, Naomi.
Sorry, it was referred back to mental health if I can at some point.
Naomi, do you want to?
Thanks. It was a comment I was considering making earlier and I didn't, but I think actually this reflects it really well. I think, you know, any of the issues that we've discussed today, they're not in isolation. You know, previously the NHS, as you know, historically we've worked in silos. So whether it's been looking specifically at general practice issues, at secondary care issues, even like, you know, deeper within secondary care, we'll be looking at urgent care, we'll be looking at planned care. And actually what this data gives us is a comparable measure. So if, you know, if the GP appointments have dropped, actually does that impact the 4-hour waiting time at A&E? You know, if GP appointments are increased, does that improve cancer diagnosis? So actually, the role of the ICB is that we're able to collate this data on an integrated, an integrated way. That means that actually we can look at the whole picture, so we can look at the process from start to finish, and not just in tiny little sections. And then I think the second point was that, it's gone out of my head now.
Should we come back to you now?
Yeah, sorry. But I think, so the main point was that actually, you know, the role of all of this data, I remember now, the role of all this data is that we can compare those. What I'd really like to see though is being able to use the social care data as well. So does the capacity of care homes impact the discharge from hospitals? Does the capacity of social care workers impact the dischargeability of the hospitals? We know it does, but I think it'd be really useful to be able to compare that. And actually, would that then possibly prevent admission to hospital if we were able to access that data from a GP perspective, and we'd be able to use that to inform practice.
We're going to hear from Rowan a bit later in terms of data into action, which is very relevant to the point. But Graham, do you give an overall response?
Thanks, Naomi. There's a theme emerging here, and we kind of shouldn't talk in code either, because it's what Joe said a few minutes ago when Joe referred to Claire's Pillar 4. Yeah. What we have to remember is the ICB hasn't been around very long, and from a kind of standing start, what we've taken on and what we've done has been enormous. One of the things that we've kind of called out and praised here is some significant progress that's been made in the space of collaboration. But actually, if we're honest and we reflect, we haven't made enough progress in that space of integration. Whether it's vertical integration or whether it's integration across sectors in some other way. And it's the question that Joe asked, yeah, how do we make sure that we segment our time between the firefighting, the delivering today, the pressures of today, and that we spend enough time on the transformational agendas? Yeah, and it's also about, whilst we are doing the firefighting, it's about giving people hope and a vision for what a better healthcare system would look like. Now, you know, we talked about the clinical strategy that underpinned the financial strategy. We're going to talk about the use of data and intelligence later in this board meeting. So I think we're building a lot of the things that are necessary for that. But actually, I think having a couple of transformational projects over the coming year that are so important that the board takes an interest and incited on them, alongside some of the delivering today initiatives, will actually help us rebalance our focus. So I think it's a good point, really well made. Thank you.
Anthony? Anthony, could you go ahead?
It was just to say, Chairman, for everyone's awareness, Paul's been a long-standing advocate of focus on mental health services, and it's scheduled at the next Quality and Performance Committee for the deep dive, which is hopefully not stealing Tony's thunder. So we'll make sure we pick up all the comments and the questions and the challenge around ambition that's just been discussed.
Okay, thank you. Were there any further questions or comments on the performance report? No, that's Tony. Is there anything you want to say from the committee, quality committee, related to this next agenda item? Sorry, I've gone.
Thanks, Raj. Just moving on to the highlight report. Just pick up on two areas, excuse me. One that's been covered consistently throughout the meeting, the urgent and emergency care issues. just to give some assurance to the board about work that's been undertaken, initiated by the System Quality Group, excuse me, that's chaired by Chris Douglas. They set about working out a set of standards for care when EDs become exceptionally busy and crowded. It's referred to as a toolkit. At the last meeting, we put this together with Anthony's presentation on. I think it was certainly not a simple presentation. It was a very it wasn't a very simple presentation. It illustrated the complexity of flow in urgent and emergency care departments, and until you see it put on one page, which Anthony successfully did, you don't realise just how complex it can be. And the efforts people make to improve one area of urgent and emergency care can have a knock-on effect elsewhere. So we worked through that carefully, but it matched very well the urgent and emergency care standards toolkit that the nurse leaders have put together. That's been very well received, and it's under initial implementation, and we'll feed back later at the board on the success of that. To be very succinct, and Chris will expand on it if you need to, it's about maintaining the safety and reasonable patient experience of people in very crowded situations who are being moved through a system that's under great pressure. So recognise that it's a difficult situation, but I think it's an excellent attempt at making sure that decent patient experiences result from that. And also it does have a knock-on effect on staff. We heard at length at the System Quality Group about the impact, the moral harm suffered by staff working in those situations, and to give due recognition, it was a Health Watch initiated idea at the beginning based on personal experience of corridor care. So it's one of those occasions where everything came together, and I think we've produced an excellent product, but we'll hear more about that later. Second point to pick up on is the care homes report. It's a periodic report. This is the second time we've had it, and it's a very substantial report now. It's by place, and it's recognised as variation, as reported by CQC, of care home experiences across Cheshire and Merseyside. What was particularly assuring was the evidence of very strong cooperative work being done between NHS and local authority around care homes. Not something I'd heard about, so it was very good to hear that, and it was a very detailed report. It did identify, however, some key themes of improvements, particularly, we've just mentioned it, infection prevention control and falls are probably two of the main areas that will become the focus from that report. So it was an initial report that sparked off what will be, I think, a substantial work plan for us. That's it for me, Chair.
Thank you, Tony. So, two issues to note. Are there any questions on this report? No. Thank you, Tony. Should we go to the report of the ICB Directors of Place? It's Deborah and Mark.
Thank you, Chair. Pleased to introduce this report to the Board, highlighting the work of the 9 local place teams as part of the Integrated Care Board. This paper is the first in a series of regular updates to the Board with regards to place-level activities, providing assurance to the Board on how our local teams are working towards the delivery of our objectives as an ICS, and by the work that we're doing locally with partners to improve health and wellbeing for local populations. I'll take the report as read, but basically to, I suppose, point out that it describes a number of areas of place activity, hopefully providing some insight into the work of each place, the common themes that we're all facing, and indeed some of the issues that also we face at a local level, but really keen today to stress some of the really good areas of practice that happen at a local level, very much to earlier points about celebrating some of the things that we are doing really well locally. There are several sections within the report highlighting some of those activities, so particularly in regards to the work of local place partnerships, areas of risk, again at place level, actions on health inequalities, some important issues around patient discharge and flow, developments around primary care networks, and some work with our providers around strategic initiatives at local level, and obviously importantly back to the financial sort of context that we're in, the use of resources and bringing to bear better use of what we have available to us. I'd like to bring to your attention a couple of areas for Liverpool particularly, and then I'll hand over to my colleague Deb from Sefton to do the same. So with regards to Liverpool, just to emphasise our commitment to tackling health inequalities, and particularly given the characteristics of our local system, given our approach that's needed around population health management. referenced in the paper under section 4.17, just to bring to the board's attention some recent good news we've had about national funding to help enhance our programmes of work, particularly around the data-led approach to tackling inequalities. And this really supports the local work that we're doing in this area and is in line with some of the work streams as recently reported in the Liverpool Strategic Futures report, which we're really hopeful will help to make a difference in the short term. Also, as highlighted in section 4.22 to 4.24, again, building on some of the earlier conversations today, the work with system partners around some of our urgent care issues and the diagnostic work that's recently been undertaken, looking to improve the flow of patients both into and out of hospital settings. And again, that's really important for us given the context I set out today. Two remaining areas, one around women's health hubs, as stated in section 4.41. Really fantastic piece of work going on locally within the city around the work with our primary care networks and indeed with some of our healthcare providers around offering a range of extended services to, again, a proportion of our population. And we're really hopeful about some of the successes that will bring in the near term. And then last but not least, with regards to the Liverpool Clinical Service Review, and the recommendations, as a reminder, are detailed out in 4.48, and obviously there's a more detailed update in Appendix 3, detailing some of the progress that's been made against the 12 recommendations, and again, just to stress the partnership working that's been required to move those forwards, and again, hopefully a helpful update with regards to where we're at, and a big 12 months ahead in terms of delivering those recommendations. So they're the highlights for Liverpool. I'll pass over to Deb from a Sefton perspective.
Thanks very much, Mark. I think it's been a really difficult report to write because there's so much happening at Place. I think we all bring as Place directors a different approach and we've got different skill base, so we work and collaborate together. The future will be that we will be collaborating more in terms of some of the really good areas of practice because we've all got great collaboration at Place, but we've also got really good projects that we could probably scale up. So that will be our challenge from Graham, is to how do you scale up the great things that you're doing and make sure you're making a big difference for residents in your places. So in terms of Sefton, I'll not repeat what Mark said, but we do have elements of all of this in each of our place. But for Sefton, we're trying to work really collaboratively through our urgent care board to improve our D2A, discharge to assess offer and home first. So we have a new programme called Better at Home, which is integrated with the local authority, where we're looking at things to keep people with frailty at home for longer, and the acceleration of our extra care housing programme. And in 2026, we'll have 90 new units of extra care housing on the Southport patch to support that particularly challenged system. We're also investing on our capital programme to support care homes with environmental issues that they may have, to be able to support people with higher acuity, and we've targeted a significant amount of our council capital programme into those areas. We're doing quite a lot of work around complex lives, homelessness and mental health, and we're trying to accelerate the work that we're doing in Southport with our ACES programme, and that's a programme to support people with adverse childhood experiences that are as a consequence of that have become homeless or drug dependent, alcohol dependent, and that's been a really successful project. I think one of the strengths in Sefton is our partnership work in the co-design of our place plan and the support of our partners. And we're really pleased to inform the board that we've been nominated for a Municipal Journal Award for our baby bonding and attachment service. I always get that the wrong way around, with Merseyside. So that's a really excellent piece of work that we've done between ICB, Council and our Merseyside colleagues. So again, supporting our children within Sefton. Thank you, Chair.
Thanks, Deborah. Thanks, Mark. Questions, comments, board members? Paul? Ruth?
Thanks, Chair. Just a further comment on Deborah's comment around the capital programme for care homes that we've been developing. The theme has been about making them more dementia friendly, recognising again the increased demand for numbers of people entering care with dementia.
Thanks, Paul. Ruth?
Well, can I just welcome the change in format that we're now seeing? This is a really welcome improvement in our understanding of place across the piece, so thank you very much for bringing the report forward. In the interest, and it's wonderful to see all the different initiatives and to hear what you're doing. In the interest of trying to get an overview for the ICB, I wonder if, as a next iteration, when initiatives are described, we can also quantify the impact to some extent. I was just randomly picking out one. Data interaction population health management platform is being used to identify patients to intervene. It'd be really helpful because we're going to discuss that later on in the meeting. Well, how many people? What impact is it actually having? Because that then gives us confidence it's the right sort of thing that we should be developing. So as you iterate this through, even small-scale projects, how many people, you know, and what were the narrative benefits for people who are using the service? So just to encourage you to do that a bit more. But the question I had was around 4.23, which was the urgent care work that's described in Liverpool. And it seems to me, going back to all the points we've had in the meeting, and I think the Finance Committee said transformation of urgent care is what we need to focus on. There's talk in there of reviewing the governance arrangements. And so I guess the question for us is, what's the plan? How quickly do you anticipate doing this? And how will the ICB learn quickly as to whether that major part of the system is having an impact in what you plan to do? So, and it picks up your point, Graham, but how do we have focus on transformation? What's the plan for how we know what you're doing on this?
Thanks, Ruth. Yeah, so, you know, multi-stranded, no magic bullets to any of this, but I think the simplicity of the response is really we know the areas that we need to improve on. So it's what happens to a patient, dare I say, before hospital, again, as we've talked about today. How can we, you know, prevent that attendance in the first instance? You know, the wraparound of community services. Sometimes described to me as we've got all the ingredients, but sometimes we don't know, put them together to kind of make the cake, to use that sort of expression. And I think that's very much the case in the Liverpool diagnostic. We've got lots of really good services, but sometimes it's about understanding, awareness and availability of those services. And I think back to earlier points about, you know, the financial strategy has to be about investing and resourcing those services more in the community to make some of that happen. So that's certainly a feature of the admission avoidance, attendance avoidance aspect to that. We know that, again, from the Liverpool system, that there's lots to do when a patient is in the hospital environment. So how can we reduce their length of stay? How can we improve access to things like diagnostics and, again, alternative services that mean that we could reduce that length of stay, which, again, means that we will get better outputs and outcomes as a result of that. And then a particular focus, again, probably of our North Mersey system to include Sefton and Knowsley, is that discharge end then, about how, again, we're making sure people are ready to go, and when they are ready, have they, again, got the wraparound support to that. So those three key components are part of our sort of implementation plan that we're currently working up. The point about governance is that, you know, all places have a local urgent care group, board, for the want of a better term, that meets regularly to discuss issues around adults, children, young people, and indeed mental health. And I think certainly in the two patches that are described in the paper, so Liverpool and North Mersey and Warrington and Halton, the Newton work has given us a renewed emphasis on the sort of the patient stories within that, and some case study reviews that, again, probably haven't told us anything that we didn't already know to some degree, but they've given us that real rich information about the things that aren't working as slickly as we would like, and what do we need to do about them. So the work for the next sort of 6 to 8 weeks is to really move on with the implementation plan about what that work needs to look like for each of those three different areas. Some of this organisations are already working on, so it's just a case of making sure that's sort of seen and cited amongst partners. Some will take more bigger scale change. I think there's a cultural piece about how we engage with our public and patient and professionals almost within that process. And then equally, internally, how can we make sure our systems and processes are as slick as possible to enable that to happen? So those plans, to try and answer your question long way round, are part of our local implementation plans. They'll be going through our local governance, our urgent care boards, and obviously they will then get reported up through the groups that Anthony's referred to earlier. around the urgent care improvement plan. Obviously, as a tier 1 system, without sort of speaking to Anthony's world more than mine, we are in a tier 1 system, so we get lots of oversight from national and regional colleagues on our plans and our approaches, and keen to say that, you know, that's always a very positive conversation, and we're doing all the right things. It's now into that implementation stage about making sure the things that we need to do are put in place, and that's an imperative for the next 6 to 12 months.
Ruth, and then I'll bring him back in, Debs.
Well, just to clarify, the governance route then is from the work you do to the urgent care group that you have. How does it get to the board? Is it through the place report or through another mechanism?
Graham, do you want to?
That's right, too many people had their microphones open, it wouldn't let me in. We're going to refresh the governance route, okay? And my executive colleagues don't know this yet, because we're talking about it in our executive group next week. But the Newton diagnostic told us some things very, very clearly, which give us an opportunity to change. And what we're going to do is we're going to set out some clear transformation projects that Claire Watson's team will bring through Transformation Committee and directly to the board in terms of a recruiting line and set that up. I'd like to talk about paragraph 423, if you don't mind, Chair, as I've kind of grabbed the floor. We need to get to everybody a copy of this Newton diagnostic. It needs to come here to the board. And Anthony and I met with Newton earlier this week to kind of edge the report to finalisation. Everybody is under absolutely no doubt that they have done a brilliant job in the system that they've worked with. It's a diagnostic report. It now needs implementing. But it said to us, I think, 2 clear messages. Yeah. There was a big opportunity to avoid admission to hospital where there are already services in place with service capacity. So why isn't it that we were able to get that patient to that service, or that patient knew that service was available? And secondly, it said to us that on discharge, too many patients are being discharged to too high a level of care dependency, which is robbing people of their independence, in some cases robbing people of their right to get back to their own home, but at the same point in time it's extending hospital length of stay, which in turn, you know, comes back to all of our issues around the front door, but it's also loading in costs for both the NHS and our partners in social care if somebody goes into a care package that's greater than what they need sooner than they need. So there's some big wins in there if we get this right. I think the other thing that this tells me is just how complicated the system that we work within. So I'll give you the example of Aintree Hospital, and I won't quite get these statistics right, but if I look at Aintree Hospital, and if I said to you, a half of their patients were from Liverpool, a third of their patients were from Sefton, and whatever the balancing percentage in that number are patients from Knowsley, the services in offer in Liverpool, Sefton and Knowsley are all slightly different, which means that that discharge journey isn't consistent. So I think the example that Deb gave us about the extra care investment in Sefton is an excellent investment. But actually, Sefton Council have chosen that through their strategic decision-making processes. They have the right to do that, but not every council has the same and consistent extra care housing offer. And so we've got to also be able to work with our partners and influence them because the system works better when it's consistent and easy to navigate.
Thanks, Graham. I think I've got Deborah and then Joe. Go ahead.
thank you for raising the questions. I think Graham's stolen a little bit of my thunder, really, because I think the other component to this is social care, and I think the investment in social care is really important because it both prevents hospital admission and we can make sure that we've got people exiting hospital quicker and with a better outcome. So one of the things we want to do really is to try and work together as place directors to describe that relationship with the directors of adult social services, and also to work closely in terms of future investment into domiciliary care, for example. So I know in Sefton that I need 1,000 hours more of domiciliary care per week to support Southport and to support our South Sefton hospital patch. So that piece of work will be done over the next few months. But again, it's about how we work together as a system, maybe in a more integrated way to deliver those solutions. Thank you.
Thank you, Devon. Joe?
It was really just to Ruth's point about what's the reporting line, the governance line. I think it's good that if it's going to be reviewed, because it's great to see two place directors here at the meeting. I think it just makes a lot more sense without us starting to use phrases like super place or anything like that. But there are communities of care, aren't there, that are more than one local authority boundary. And it's to Graham's point about, I guess, maybe getting place directors in the right groupings represented at the board to give us a more cogent view of what consistency looks like. I mean, we can talk about integration if we want. I think we don't need to sort of bother with that. It's actually about consistency and constancy and those sorts of things. And therefore, when we start to think about the Newton piece, we just need to map in the governance route to the board, because there is from place to here, urgent care to here, but then there's more than one place, in this instance 3 places, that needs to map to here. And we'll not get a full view if we don't think about governance in that context. But I think it's a real improvement to see this more than one place director representing the same issues in a sort of cogent way. So thank you.
Thanks, Joe. Does anybody else want to just make some final comments? One, firstly, I really liked the report. It's quite long, but there was lots of detail in it that were relevant. And I'd emphasise Ruth's point about metrics. We have to see metrics in these reports. I'm going to exaggerate and be unfair. So I have seen a lot of analysis. I've seen a lot of plans, a lot of proposed governance changes. But my ears pricked up when you talked about implementation. I suspect our focus on implementation is at best restricted, given the bit of the history that we've been through in terms of reorganisation and so on and so forth. But I do think the board needs to hear more about implementation and our plans around implementation and the risks and issues that there are around there on our key metrics. I don't need to rehearse those with you. With that said, Deborah and Mark, what do you want off the board? Now, if you haven't got anything immediately, I think we need to hear more from the place directors in saying, you guys need to enable us to do this. And I know you have conversations with the chief exec and the exec forum, but there's some stuff that needs to come to the board as well. If you've got an immediate response, Deborah clearly has.
I think it would be really good to take that back to our place director colleagues, because we meet regularly, and to pose that question to all of us, and then we can come back with a response about what we'd like to see from the board in terms of support and how the board can help us. But I think also it is helpful that there is interest in what we do at place, because it's a tough job and we do a huge amount of work with our partner organisations. So it's a really great opportunity today to be able to represent our 9 places. But what we'd like to have is, as well, a bit of a forward plan from us. So, you know, again, two-way thing, asking us what you want to see coming forward as a piece of work, and setting that piece of work for us. So, thank you.
Thanks, Deborah. And that ask about the board, I'm really thinking about the implementation space. Okay. Paul, final comment.
Thanks, Raj. At the previous board, I've asked the question about different models of integration. We've got 3 of the places that have a so-called more integrated model, and Deborah demonstrates that from Sefton as she oversees NHS and local authority provision. I'm just wondering, again, at what stage we're going to look at those models overall and say, are those three that are operating in that sort of way, are there issues that can be picked up from there, or is the Liverpool model and how they're operating, how are we comparing? And I think in response to Graham's challenge about local government making different decisions, actually in Sefton and Extra Care, we're catching up with some other authorities. I think our local authorities and social care are very much going in the same direction. I think we've experienced lots of historic issues, particularly in Sefton, around the size of our residential and nursing home situation. So we all come at these things from a different point of view, but I think we're heading in the right direction to try and create as much independence and healthy lives for people as we can in partnership with NHS colleagues.
Thanks, Paul. In response to your first question, when we were in New Brighton, that question was posed and Graham outlined his plans to come to us at the end of the summer, perhaps November, with the revised model that takes into account the learnings that we've had in terms of what models work best in different places. So if you're comfortable with that, we'll keep with that plan. If it's earlier, it's earlier. Neil, should we go to your agenda item? Highlight report for the Chair of Audit.
Yes, thank you, Chair. I've got two recommendations from the board from the Audit Committee. The first is around proposed changes to the scheme of delegations, which we've scrutinised and the Audit Committee are recommending to the board to approve. The details are in the pack. I'm happy to take questions. Otherwise, I would ask the board if they would approve the changes.
Okay, should we take that? Any questions or comments before we seek approval for the scheme of delegation? No. It's on.
Second point, right, that came up this morning in
Neil,
terms of the discussion.
Just pause for 1 second there. I haven't actually got page numbers. Matthew, could you help the members of the public? So I think we took approval on that. Sorry, Neil, go ahead.
This morning, you had a discussion before the board meeting regarding amending the Women's Services Committee's terms of reference and in changing them from approving the case for change to endorsing and recommending the board for the case of change. Do you wish to support them now or for paper to come back to the board?
I think we're going to support that now unless anybody disagrees. Yes, let's act in that agile way, I think. Yeah, thank you. Secondly,
our recommendations to the board regarding the changes to the risk management strategy. And you'll see in there that a timely review led by Donna and Matthew, excellent results, proposed changes around the risk matrix, escalation criteria and reporting frequency to make the risk management strategy more usable and clearly more acceptable in terms of escalation to the board. Again, the details are in the report. I'm asking the board if they're happy to support the recommendations.
Thanks, Dale. Any questions or comments? No. I must say, Neil, I really like these recommendations. It does, I think, bring clarity and more assurance that we will have things escalated to the board more effectively. So we'll seek to approve those. Yes? Yep. Thank you.
And just a couple of other points to highlight, Raj, because we're getting to the end of the year for annual accounts and annual reports. I'm pleased to say everything's going on track, although there's an awful lot of work for the officers to get us through there. Our internal audit plans are on track for the end of the year, so we're looking for a good head of internal audit opinion this year. Our external audit work on assurance and risk, the draft outline is looking really excellent, so well done to everybody. And the counter-fraud plans are all on plan. So we're very much on track. Well done to everybody for all the work, because it's been quite an enormous amount of change this year, but everything's going to plan, fingers crossed. I shouldn't say that really, should I? But everything is going to plan.
So an optimistic audit, Chair. So that's a rare beast. So that's good to hear. Are we okay to move on from this? Yeah. Tony, can we go to your report? Thanks, Neil.
Thank you, Chair. Just a brief comment, if I may. The Remuneration Committee previously had asked for some assurance about, we've termed it the readiness and competency of the deputies of ICB execs and place directors. The report received gave that level of assurance, particularly around the ability to act up and provide short-term cover, but indicated that there will be need for development opportunities for deputies going forward in the future. That's all I've got to say, Chair.
Any questions for Tony on this report? It's here for information. No? Okay, thank you. The next one is a report from the Children's and Young People's Committee. You can see the report in front of you. I'm just trying to get through to it, through all these pages. Any questions as I'm looking for it? You can see the highlights that I'm making. I think some really good progress on getting a clear line of sight of what's happening around children and young people across Cheshire and Merseyside, and with a coalescence around 4 priorities that's been accepted through various different forums that enables us to give some focus on some priorities in coming years. People happy to accept that report? Yep. Women's Hospital Services report. We've covered a bit of this in the main meeting. Is there anything further people want to say or comment on that report? No? Okay, thank you. Transformation Committee, Claire?
Thank you, and apologies to everyone. I think this agenda has got is the reason for most of the papers in the board. So we have attached all of the specialised commissioning delegation agreement documents, so apologies in advance. So firstly, at the last meeting we recommended a change of the terms of reference to the committee and a change of name from Transformation Committee to Strategy and Transformation Committee, and with that we are recommending to board that it is chaired by a non-executive. We will work through the details with yourself, Raj, on who that is and how we move that forward. But with the change in name and with the change in chair, it's about a slightly broader portfolio and remit for the committee to take account of Pillar 4, some of the sort of financial strategic objectives, pull through the joint forward plan and the healthcare strategy reports, and some of the wider transformation programmes. So that's one of the recommendations, Chair. Is it okay if I pass on to John? We talked about the cyber security strategy and discussed that at the committee, which had also been to CMAST and other committees within the ICB, and recommend that to board. So, John.
Thanks, Claire. Thanks, Raj. Yes, so in the pack today is the draft Cheshire and Merseyside cyber strategy, and if I can just put this in a national context, last year the National Cyber Resilience Strategy was published. It's a 7-year view, and it stresses the centrality of this agenda and its criticality in how we deliver services. Any loss of our digital and data capability in current times has an almost immediate effect and risk to patient safety and operational efficiency. In that strategy, it's quite explicit around responsibilities throughout the system, down to individual organisational level. And for an ICB, it sets out some clear areas of responsibility, first of which is having an ICS-wide cyber strategy, which we're asking for approval for today. Other responsibilities of the ICB are around identifying funding for the delivery of that strategy, managing risks as a collective, investing in ICS-wide plans to control risk, delivering a cybersecurity program with metrics and measurable assurance, and looking forward, working with suppliers and anyone who provides our digital and data capabilities to make sure we buy and build safe systems. And probably equally important is having a really coherent response in the event of a major incident. Cheshire and Merseyside's in a really good place in terms of relative to other parts of the country. The last few years there's been a real collective, collaborative push amongst the CIO and EPRR colleagues. And there's been a programme of work delivering some common capabilities, working on common standards, looking at what we need going forward to make us safer. But I would say that's been a coalition of the willing to date, and what this strategy calls for is turning that programme approach and that best endeavours approach into a more robust business as usual capability, whereby we defend as one, we collectively manage our cyber vulnerabilities and cyber risks as one ICS-wide collective. And that our strategy and our response to those challenges, we set out 9 strategic objectives: governance, risk management, incident management, how we procure tools to support us in this, how we manage third-party systems, and that's a big one, how we procure and assure ourselves that what systems are going in wherever in our system, they're appropriately secure and well managed and maintained. Big piece around people and culture. That's everyone having a responsibility around this agenda and being sufficiently educated and adequately skilled. And then more specifically, us retaining and developing what is quite a hard to reach, hard to recruit set of skills in this specialism. And then a big theme running through this is around us having common policies, processes, knowledge sharing, and in that governance approach, having more of a formality and more teeth in terms of assurance, giving this board ultimately the view of our vulnerabilities and progress to closing gaps. Also in the strategy is, so there's turning that collective into a more formal structure, but then there's a couple of specifics around creating a regional security operations centre. And the strategy doesn't set out to do this overnight, recognises the financial position we're in and some of the challenges around setting this up from a standing start. But this is about having a 24/7 view of threats as they emerge and present, and then a 24/7 response to those threats. We've had lots of discussions, as Claire said, at various governance groups and informal groups around the patch, and we'll continue to do so. Really productive discussion with CMAST, the Acute Provider Collaborative CEOs, who recognise this as probably our #1 digital priority, and also recognise some of the solution is in pooling of some of those rare skills into a federated centre of excellence. So there's a commitment in the plan to work some of that resource ask and the detail of what our proposed organisational form might be. There was also discussion at Transformation Committee around how we manage this risk, and question asked whether this board should have on its board assurance framework an explicit risk around loss of services due to cyber attack. And we've got there are two risks in the digital team's risk log that talk to this. One is around risks to the ICB systems, and one is a wider system risk which talks to that catastrophic loss of systems due to a malicious attack. That's working its way through the ICB governance up to risk committee, and my personal view is that it is a risk that this board should be cited on in terms of likelihood and what are our controls and how we're progressing those controls. So we're looking for approval of the strategy today. A lot of the work in there is up and running, but I think the main change, should we get approval, will be some of that formality in quality assurance and some of the authority to mandate some common standards. Thanks, Raj.
Apologies. I'm going to break it into two. We need to come back to the terms of reference recommendations in terms of the overall strategy and transformation committee. But on cyber security, John's posed a question to us in terms of approval of the strategy. Any comments? Yeah. Graham?
Chair, I'm absolutely content with the strategy. It's a good strategy. It's very clear. But there's quite a lot of pages here. and I might be about to ask a question that's answered within here, and I apologise if I do. But it's a context question. So given that cyber security and the way that you set out and approach this is very much associated with how some of these services are hosted and managed. Yeah. My understanding is our historic arrangements for shared services is we currently have at least 3 different hosts of major IT infrastructure in Cheshire and Merseyside. Now, I'm not sure whether that gives us advantages, disadvantages, whether or not we are assured of the consistency and whether all 3 meet the same standards, and whether or not there is a kind of convergence piece here. And when you talk about a 24/7 threat centre, does that mean that each of our hosts have a 24/7 threat response? Or does that mean you're having a shared overarching threat response? And you might want to expand for the sake of other board members what I mean by I think we've got 3 hosts for the kit and connections going on.
Thanks, Graham. To expand on the organisational form and the support arrangements we have for ICB Digital, through geographical accident, those services, and that's corporate IT and primary care, ostensibly those 2 main areas of focus were historically provided by 3 shared services: Midlands and Lancs CSU, Mid-Mersey Digital Alliance, and Informatics Merseyside. And they're divided on geographic historic lines. They work really closely together, and one of our big checks and assurance models in that is our DSP return and some of the cyber security elements that we have to answer as a collective. It does mean that the infrastructure that provides the IT for this meeting is provided out of one data centre, and you might access services on another laptop in the ICB through another. So we've got a disjointed infrastructure. Some might say that's more resilient because your eggs aren't all in one basket, but it creates an overhead in managing that. When I talk about the Security Operations Centre, that's beyond the remit of internal ICB Digital. That's on behalf of the whole system. So all our providers and ultimately partners in the system, defending as one, and having a single pane of glass view of, in any of our organisations, how well they are patching vulnerabilities. So when a new threat emerges, quite often a supplier will issue a patch that you need to apply to all your machines to close that risk off. There's a piece here around us being aware of all of that vulnerability and our speed of response across all our providers. And that's where the governance comes in. There's an understandable reluctance in some parts to share the dirty linen, and show vulnerabilities. I think we've got a good collaborative approach, but we need more formality on managing that as a risk in the same way we manage some of the other performance reports that we've heard today. The Security Operations Centre just does that on a 24-hour basis. And there's different ways to fulfil that. That could be outsourced, it could be pooled resource from within our organisations. But the moment we stop short of that, we all do this in our own individual organisations in the way we see fit. And I think that's inherently not as safe as a single approach. And that's essentially what the strategy talks to. Recognise it's not an overnight fix, but equally recognises we've come a long way and are probably well placed as a system.
Can I just ask another question? Sorry. Adding on to that, you talked about the providers. Primary care.
Yeah.
I suppose, where do you see that in the risk profile? Because it's a very different profile, and you mentioned maintaining the cyber risk.
Yeah, so, and this is an example of where this gets very complicated very quickly, because the infrastructure that typically a GP practice is using to access its clinical records is funded in different ways. It comes through a national route. There are various bidding processes to access that funding. So to keep us, to to recognise our current state of vulnerability and risk is one thing, but then to have the associated financial freedom to fix that is one step removed in primary care. So it's worked well for a while, but it does feel slightly at odds with this. And then similarly, where the risk really is below the waterline is just appropriate investment in this stuff at every provider level. So we're only as strong as our weakest link. And quite often in constrained financial times, we might try and make a laptop go another year beyond its life. That almost inevitably makes it less secure because it can't run the latest software. So there's something about a minimum percentage of turnover in each organisation that should be apportioned to this agenda and keeping the core infrastructure up to date. But primary care is particularly tricky because we don't hold all the levers directly.
Can I bring in Ruth and then Claire?
I just wanted to pick up that point about the financial ramifications of this strategy. Cybersecurity is absolutely fundamental now, isn't it? And we need to be confident that we're clear, A, who's accountable for keeping up to date in the different components of the system. So this strategy is not about the ICB itself taking on all that responsibility, but we do need to be explicit about the minimum requirements to maintain cybersecurity in all aspects of our healthcare system. And increasingly, it's not just laptops and computers, it's clever gadgets that connect to the internet and all sorts of things. I mean, it's right through a diagnostic, all sorts of different elements of this, aren't there? So I guess for us, in the time of financial difficulties and pressure, what is our expectation about how we resource this going forward and being explicit about that? My second point, quite separately, whilst it's welcome that the NHS is really taking a strong focus on cybersecurity, are we working with voluntary organisations, local authorities, academia, where we have critical interfaces, where we want to share data and systems and access? Is the strategy going to make sure that we're not getting in the way of progress across organisations and enables that, but also enhances the security aspect? Thank you.
Okay, I'll take the last point first. So, yes, the ambition within the cyber team and the cyber government, the existing groups, is to see the system as a whole. Again, it's baby steps. I think we've got explicit NHS responsibilities. But as I said, a vulnerability in a hospice could quite easily take down the whole system. So we can't be selective around how we manage this. So the intention is for this strategy to be a system strategy. I think we've got some work to do. And you see this when an incident plays out. Quite often organisations get in the bunker and try and resolve it. And actually what they should do is signal to the whole system what the problem is. That's where the formality of the governments will help. In terms of recurring funding, there is some national funding to prime some of this. So we've had some capital late this year, which is being pointed towards that capability, that single pane of glass dashboard view. So building our tooling capabilities. And there's some small revenue pieces coming next year, we hope. I think the next step is to just, in a relatively modest way, define what we need at the centre, because there's an offer from organisations that pooling some of the resource will solve some of that. It just needs a small leadership core with this very specialist skills to manage some of this, and that there's no obvious route to a recognised budget long term there. So I think we need to work through that and recognising our financial position, continue to make progress with what pots of money become available.
John, just on that last point before I bring Claire in, I think it's really important for this board to understand, given the best of expertise that we've got, what is the minimum viable product ask in terms of resourcing, and rather than building up from available funding sources, so we understand the gap, at least here. Could I bring in Claire?
So my point wasn't about the cyber security strategy. It
Oh,
was
was it?
to try and bring us back to the best of
Let me just conclude
discussion.
cyber security. Yep.
John, the notation of sort of short, medium and long term against objectives here and so on. Is that because, you know, the longer term ones are just harder to do and require funding and things like that? It's because what I'm struggling with in my head is these objectives and the short, medium and long term versus cyber attacks aren't unknown to us. What do we know about them and what are the major points of vulnerability? And to close those, are some of those closure opportunities in the long term? Do you see what I mean? You know, are we going to put our effort where we think the problem is likely to emerge? And I can't tell from this.
It's a good point, and I think the strategy probably reflects a number of years living within our means and putting in an ask that's reasonable, not disproportionate. The national strategy actually talks, its first pillar of focus is look at the greatest harm. So that might require us to do something more expensive or fundamental up front. So I take the challenge. I think we could be in a quickly better position just with more formality of reporting and single view of reporting, that we could then ask the right questions in the right places.
Okay. Is there anything more on the cybersecurity strategy? Duncan, just be clear in terms of the resourcing question that you put into the paper. Are you seeking approval from this board for that resource?
No, it's an indicative model, and I think there are 2 or 3 discrete business cases that need to follow. One around how we would deliver a security operations centre, and then to the challenge, what's the minimum viable product of a central team.
Okay,
so I'll bring those back through the appropriate process.
Thanks. Claire?
Thank you. So a final recommendation, and then I just want to talk about SpecCom. So as part of the meeting last week, we had a long conversation about transformation programmes and you know, the intelligence behind that, and therefore the recommendation from the committee to board was that the Data into Action programme reporting moves from board to strategy and transformation committee. I've just caught up with Rowan before the meeting, and I know Rowan's talking about the work later. So I'm happy to leave that recommendation until Rowan's item, if you prefer, Chair. And then we can discuss dotted line and straight lines. But I think either way, it's just really important that we get the intelligence and all the information into all of our commissioning and transformation work. So I think that's what the committee was asking for.
Okay.
So
just before you go into SpecCom, so the terms of reference change. It's more than the terms of reference. It changes the title, you know, and some of the functions of the Transformation Committee to a Strategy and Transformation Committee. The reason why that change was done was comments made from the board and within the executive group about, one, ensuring that the board had greater sight of what's going on, and secondly, comments have been made in this meeting about how do we ensure that we can see better, quicker implementation of some of those transformation themes. So question to the board is, does that terms of reference do it for us? And are people comfortable with that as it stands?
I mean, it would be helpful if we could, but what we've also said is we would probably want to have a bit of a refresh and a workshop in 6 months' time, which might then help inform the work in 25, 26.
Okay.
For the
so just in terms of the terms of reference, people are comfortable signing that off, and as we'll be able to review the workings of it in 6 months' time through a workshop. Yep,
Thank
good
you.
stuff, Claire. Sorry, Louise, do you want to ask a question?
Thank you. Really helpful to see this, and thanks for allowing me to be in attendance today. Relatively new into the Health Innovation North West Coast role as chair, but one of the things, and I know Claire and I have already had a preliminary discussion, I think there's potentially a lot of alignment and support that we can actually bring to some of this transformation piece. So it's perhaps not changing what's proposed here, but just putting a marker down that when that group's considering who's involved as an attendee, it may be helpful on a programme basis to include that.
I think that's a great offer.
Yeah, and we have had that conversation and we discussed it at the meeting, so very happy to pull that in, so thank you. Just finally then, and quickly, so I just wanted to raise specialised commissioning because I think 1st of April, we take on responsibility for, we take on delegated responsibility for 59 services. So if you remember at the last board meeting, the board delegated authority to the Transformation Committee to approve the key documents regarding the delegation of those services, both for the ICB individually, but as part of a joint committee with the other two ICBs in the North West region. So for absolute completeness, we've attached them. I'm not expecting anyone to have read them because there's been a lot of work. They've been discussed at length at the North West Joint Committee. They were discussed at length at the Transformation Committee. And thanks to everybody who's worked on those. So we do recommend them to the board, having approved them and being satisfied at the Transformation Committee. We now need Graham to sign delegation agreements, and as it happens, we are being chased for a signature, because obviously today is the last working day before the 1st of April. But this will come through the Strategy and Transformation Committee, but we have established a new internal specialised commissioning operational group, which will be the engine room, the sort of the contracting commissioning, the sort of the quality and the outcomes. And obviously this is a new responsibility for the ICB. It has got a financial pressure to it for us, and, but it's something that I think in terms of the integration agenda and the end-to-end pathway, it's really important that we look at this as a key priority into the new financial year. So recommend those papers, Chair, and obviously we need to get Graham's signature on them as soon as possible. Thank you.
Just let me make a comment, which is, you might have already given this to us, so forgive me if I've forgotten. So on the principle that form needs to follow function, are we yet clear, or when will we be clear on the objectives that we will have for specialised commissioning in after we've taken on that responsibility? And how are we doing that work?
So for 24-25, we will continue to work hand in hand with the regional team on this. So we'll have all the support and resource from the current team that work in NHS England. They will work with and on behalf of the 3 ICBs. We will set our priorities. We already have a work programme we are developing through the operational group, which we can present to board or through the Strategy and Transformation Committee. The key agenda is that we almost take the specialised heading off them and they become part and parcel of our integrated commissioning agenda. So we will set outcomes, we'll set ambitions around some of those services. Some of them are nationally prescribed, but I think the advantage of us taking responsibility is we can get them integrated into our work programmes, and actually, you know, talking about stroke and other services, it's not just the small element of that end of the pathway, it's that sort of shift left agenda and really focusing on the greater sort of population outcomes.
Okay, thanks, Claire. So I'm going to assume from that description that we will have a set of priorities that are articulated in terms of the benefits we expect to get from the approach that you've outlined, especially moving specialist commissioning into integrated commissioning. That'll be really important for us to see. So, terms of reference, people comfortable? Yeah, let's approve those. Thank you.
Thank you.
Can we go on to primary care, I think?
So there's one item to highlight on the Chair's report of System Primary Care. It's really important, and it's the Dental Improvement Plan. So from a System Primary Care, we have reviewed, we've challenged, and we're ultimately putting this in front of the board now for approval. I think everybody in the room is totally aware that improving our dental access is an absolute priority. I know Sarah's nodding. I was just going to add that Health Watch, thank you for providing the voice of the community, and we know the impacts that not having access to dental care have caused to our communities. So ultimately, doing nothing isn't an option for us with this. So we have funding for the 2-year plan. That has been confirmed, I'll look at Claire, by our financial colleagues within the ICB. It's currently ring-fenced through underperformance. This activity can be scaled down if the ICB financial position warrants it. So just to be clear, the money is there, it's ring-fenced, but it can be scaled down if we actually had to, which I hope we don't. I think it's really clear that it's a really ambitious plan. It's going to take time and resources to mobilise, so the amount of money that is the request that is in front of you is an absolute maximum amount of expenditure. What I'm asking really is for you to note those pathways that are going to be impacted, because we have done a real focus on priority on vulnerable groups and also on improving our inequalities in the community for dental access. So that's it from me as a chair. I'll hand over to you, Claire, and questions.
Thank you. So hopefully board will remember we actually developed an initial dental improvement plan last spring, and we initiated that, but myself and Erica asked for it to be more ambitious and for it to take account of the new national recovery plan from the government. So as Erica says, we have discussed this through System Primary Care Committee. It has been worked up with our dental network, so that's sort of all sort of elements of provision across dentistry, and obviously including input from the local dental committee and Health Watch. So we're proud to recommend it. It is absolutely about responding to all the complaints and criticism we get from the public through our national and local politicians, and it's absolutely, as Erica said, trying to target the most vulnerable. And we will do that in terms of how we initiate some of the pathways. We'll focus initially on the areas of greatest need before we sort of spread. So there are some pathways around access. Obviously, we've previously approved the oral health piece. We're looking at a sort of proof of concept around a dental access and workforce development centre, something that we've got real support and enthusiasm with our dental network. As Erica says, we're not asking for new money. This is actually underspend on the dental contract. So we know as of the end of February, we're performing currently 82.7% of our contract delivery for our general dental practices. But the slippage or the underspend is what we're asking to spend rather than asking for growth funding. As Erica says, you know, this is the total ask. We won't spend it all in year, but this is more of a 2-year plan. So it's about kicking this off, getting things moving, and absolutely targeting the most vulnerable. So hopefully you'll support this. We recognise in the financial, situation, it's a big ask, but we believe it's the right thing to do for our population, and absolutely meets the needs of all those sort of queries and complaints that we've been having over many years. So thank you.
Thank you, Claire. Sarah?
I have to say I really, really welcome this plan. If we're honest, it's not going to fix everything. Most dentists have got waiting lists that they've been taking on over the last few years when they've not been taking on. And even just to clear the people that they've already got on their books they're waiting to see will take time. But I think it's fairly clear that the National Dental Recovery Plan is not going to make much difference locally. And this is the best that can be done within a dental contract that doesn't work and the limited financial budgets. It seems to me the best way of making sure we spend that dental underspend and spend it as effectively as possible, getting some people out of pain with a more effective way of dealing with things. Just relying on emergency appointments does not work. It's a really poor experience for patients, poor experience for dentists, and really bad use of money. I've seen so many people who might have had 9, 10 repeated emergency appointments, 10-minute slots to get rid of an infection, give them antibiotics, maybe pull a tooth out, but no ongoing care. So the pathway with the Urgent Care Plus and Pathway 3 absolutely vital in trying to tackle some of that. I've also seen repeated people who it's been knock-on effects on the rest of the NHS, people whose diabetes is unstable and their GPs refer them to a dietitian for advice about eating. Well, they've got no teeth. That's the reason why they're not able to maintain a healthy diet. It's the absolute least we can do, absolutely essential, and I really, really welcome it.
Thanks, Sarah. Rowan? Then I'll come to Claire.
Thanks. One of the things we've got to get right here is you've prioritised, quite rightly, those most vulnerable patients to come forward for their care. I guess the challenge might be, and you might say, no, this is sorted, our ability to seek assurance that that's been delivered. I.e., have we got the reporting mechanisms through from our dentists to be able to assure us that that approach is working in the way that we would expect it to? because again, where we focus on the evidence that we are delivering, that's the assurance this board would seek, because it strikes me that there might be a piece in there around supporting them around the reporting side of it. Thanks.
I think that's a reasonable challenge, and I think it was raised earlier in the meeting, wasn't it, in terms of making sure that the metrics we collect are not just about numbers, and I think that's where we are at the moment with a lot of reporting, and Jonathan will talk about this in a minute in terms of the general practice access recovery. You know, it's not just numbers, it's about outcomes, it's about experience, it's about pain or trying to reduce that. So as part of this development, we are setting, I said earlier, we're setting up an improvement group, improvement board, and absolutely those metrics will be pivotal for that. And I think that's why it's important that we include, you know, Health Watch and others to help inform what metrics we collect and what information. But by working with the dental network, which as I said covers, you know, general dental practice, community services, secondary care, they are really keen to do this and really keen to work with us, and they will pull out those metrics. And I think, you know, we have to work with places as well in terms of understanding where those areas of need, and obviously with Ian and the population health team in terms of, you know, those key areas where we'll focus the services first.
Thanks, Claire. Claire?
Yes, thank you. It was just to confirm the position on the funding. The budget is indeed underspent, and it is ring-fenced nationally, so it isn't a source of funding that could offset any overspends anywhere else anyway. That is not an option available to us from a national perspective. So it's just to confirm what Claire was saying around the investment of this ring-fenced budget.
Thanks, Claire. Okay, no further comment from me. Firstly, thank you for doing this piece of work and the approach that you took in terms of making sure we were engaging with the public through Health Watch. And the sorry, Dame, you wanted to say something, didn't you? Apologies, you go first.
Thank you, Erica. Thank you, Claire. I think one of the things that's really clear in here, and it came down from the national plan, was better payment for dentists to do NHS work. And clearly the hope is that will enable those dentists to switch time from you know, doing private work to doing NHS work, and itself give more capacity. But I don't know whether or not the market will respond to that. But actually this was about listening to the profession and fairly rewarding them. But that's why it's fundamentally important within here, and the part about the dental access and workforce development centres, for us to look at the creation of new ways and new access points to do this, and almost something that's new market entrant. I thank you for the work that's been done to date on putting that idea and that concept together. But for me, this is the fundamental thing that could just give us a step change in the level of access to our population. And then the final thing that I want to say, and maybe this is just a piece of work around better understanding and some work that could be done with Health Watch, is this is all done within the context of access to NHS dentistry requires a co-payment. Yeah, you know, it is the law, it applies to every part of this country, and we need to just examine how we are communicating with patients so that they know and that they understand.
Thanks, Graham. Yep, so in terms of great ambition, I would like to see our performance report amended so that we do see some key metrics that I know will be in development, especially those metrics that tell us whether we're making inroads into those more marginalised, deprived communities. I'm sure we can do that. Let's get it into the performance report. That'll give the board assurance about the progress on this. Good work. Thank you. If we can go on to establishment of the ICB Research and Innovation Committee. I think we're on to
Access recovery plan.
Oh, sorry, yes, I've missed one. Access recovery plan.
Okay, thank you, and welcome Dr. Jonathan Griffiths, the ICB's Associate Medical Director of Primary Care, who's going to talk through the detailed slide. But before we do that, just to remind Board that we presented the first response to the NHS England's Recovery Access to Primary Care policy document in November. It is a major national delivery statement on a par with elective and urgent and emergency care recovery. And obviously it's a key document published to support general practice to help deliver greater access to the public. So it's absolutely critical at all times, but particularly at the moment. You'll see in section 2.8 some of the updates from the Board asked and we've done since then. And obviously we're continuing to work with Health Watch as we said we would, and we've commissioned some work from them to take more meaningful temperature checks in between the National Patient Service Survey to actually understand from our public the difference that this plan has made to them in terms of outcomes and improved access. I'll hand over to Jonathan now to talk through the progress we've made, but I think it is a year of challenge as we go into 24-25 for general practice. Jonathan can update on a very, very recent vote that's come through. So 24-25 is a consolidation year for GP contract. It's a single year contract. It has been published. And what we're trying to do is work with what we've got and obviously focus our investment and our priorities on, again, the most vulnerable, improving access at the same time as supporting general practice. So I'll hand over to Jonathan, please.
Welcome, Jonathan.
Thank you. Thanks for having me back. Good to see you all. Good afternoon. So you had a slide deck as part of the pack. I'm not going to go through that, but I want to just highlight a few points. We know that this is really important. We know that patients want to have easy, simple, straightforward access to their general practice. It can both be true that GPs have never worked as hard as they are right now, and the numbers of appointments are enormous, over 1 million appointments every month in Cheshire and Merseyside. That is true. It can also be true that patients are still saying they're struggling to see their GP. And this plan is trying to tackle that. So we know it's important for patients. We know it's an important national policy ask. We know of our patient survey last year where there was, we scored lower than previous years in terms of satisfaction rates for general practice. We know what our local health watch is saying in terms of what our patients want from general practice services. So what's been done? So empowering patients, Pharmacy First has been launched now, and we've got most of our pharmacies providing additional service. So there's a range of health needs where patients can go directly to their pharmacy and receive care rather than going to their GP. That is up and that is running. We're waiting for some national figures around exactly how that is working and what the numbers are. But on the ground, from a pharmacy point of view, it is a positive reporting. There will inevitably be some tweaks and niggles, and we're going to try and avoid patients bouncing between general practice and community pharmacy, which I think in the opening months of this is inevitable. But by and large, we feel this is working quite well. Cloud-based telephony. So you'll have heard a lot about this. A lot of money has gone into ensuring that practices have telephone systems that are fit for the future. Some were about to just hit the buffers and just collapse, and so that has been corrected. So we've got, I think, 141 of 142 new contracts have been signed. So we've got practices who have got these new systems. Now, you need to understand what this is and what it isn't. So this is new technology. You won't notice it particularly when you ring up your surgery, but it allows a few extra things to happen. It will allow callback functionality. It allows people to be using the internet to be calling, so I can copy and paste the phone number from the record into the phone. It's like a minor thing, but when your eyesight's failing and you misdial, things like that are really important, so that really helps. What it's not is more people to answer the phones. So if you had X number of reception staff to answer the phones before, you've still got X number of reception staff. So it doesn't necessarily increase the capacity or ability to get through, other than we can have callback functionality. But that is really important that that has been done. Building capacity. So there are additional roles. We've talked about this a lot, and most of the funding that has come through to general practice with regard to this plan is because of the additional roles reimbursement scheme. So lots of new staff, 1,264 additional direct patient care staff into Cheshire and Merseyside since December 23. This is not more doctors. So these are additional staff that are providing patient care, but doctors are specifically excluded from this scheme. So there is still an issue in terms of a workforce crisis in general practice for GPs. And what there's not been is an uplift to the core contract that would allow that to happen. So Claire has alluded to the contract. So the NHS England has offered a contract to general practice for this coming year, offering a 2% uplift. The General Practitioners Committee of the BMA have rejected that and have now gone out to a referendum of GPs to say, do you or do you not accept the contract? A yes or no question. The results have come in today. So 61% of GPs took part in that ballot, and 99.2% said no. So have rejected that. Now this is not a vote for a industrial action at this point in time. This is an indicative vote, if you like, to see what people are thinking about the contract. Any further action in terms of industrial action for GPs will take place later this year. Now, this is really significant and could be very significant for our system. We don't know what this will look like. It is unlikely to look like industrial action that you might expect or that we have seen from colleagues in secondary care. So it's unlikely to be GPs walking out of their surgeries not seeing patients. It is more likely to be working to rule, not engaging with the ICB, not engaging as well with secondary care colleagues potentially. Potentially saying, I will only see 25 patients a day because that's the BMA safe working limit of patients. So reducing access requirements. So it's something that we need to have on our radars very much and take very seriously moving forwards. Going back to the slides that you've got, one positive thing I think that we are doing is trying to reduce bureaucracy. We are leading the way nationally with our primary secondary care interface work. That's not to say we have that fixed. It's still a big challenge, and if you ask many GPs, they will say we are still receiving lots of work that we feel our secondary care colleagues could or should be undertaking. Likewise, I know my consultant colleagues would say there's plenty of work that they're seeing that we could perhaps be managing in primary care as well. So work needs to be done on that, but we have published our comms toolkit earlier this year, which is on the website for you all to see, which I think will help us to make some traction with regard to that. So what you have there is, you've also, by the way, got details of all the place summaries that I'm not going to go through, but you can see what's being done in each individual place. There is much work that needs to continue to be done. All PCNs are working on their capacity and access improvement plans. We have some challenges with regard to self-referral that need to be tweaked and sorted out. GP retention is still a problem. We need to model our workforce planning as we go forwards as well. But we are making some progress. You will have realised this is not really a primary care access recovery plan, it is a general practice access recovery plan. There is work around pharmacy in there, but only as a way to support general practice. There is nothing in there about dentistry, but you've already heard about our plans for that. There is nothing in there about optometry. So those are gaps that we are not hearing about particularly at all. I guess my main thing I wanted to leave you with is the sense that in general practice, people are not happy. GPs are not happy. They are upset with what is happening with their contract, and that could have some serious implications for us. Thank you.
Thank you, Jonathan. Any questions or comments for Jonathan? Naomi?
Thank you. So you've heard me speak before about the access recovery, particularly with regards to the telephone systems. It was just, I know Jonathan has explained a little bit about the kind of, I suppose, the process of the difference that telephone systems will make. But and as he's already said, it will not increase the number of people to answer the phones, and it will not increase the number of people to actually run appointments. However, what it will do is it will give us the information to be able to see on a Monday morning, do we have 10,000 people ringing for appointments, and on a Friday, do we only have 3,000? Actually, therefore, we need to, we need to kind of top load the week with clinicians, and so we'll be able to vary clinics based on demand, and I think it's that information that will be really important to be able to improve access to primary care. That's the first one. The second point I just wanted to make was I think we need to acknowledge that so when the ORS system first started in 2019-2020, there was a gradual increase in funding up until 23-24. That funding has now plateaued. We've not actually had confirmation of the funding for next year, but the comms that we've had so far is that there will be no increase in funding for next year. So for the staff that we have now, that's it. We can't expand any further. We can't bring in any additional colleagues. Also, just to mention, because I think it is really important about this new GP contract and the proposed 1.9% uplift. This is not the same as the junior doctor strike, and this is not the same as the consultant strike. They were very specifically striking for more pay for them individually. This is more, this is not about GP pay. It's not about what I'm taking home at the end of the month. This is about how much my practice gets. So that's how much can I pay my reception staff, my secretary staff? Can I bring in extra nurses to do extra immunisations? Or actually, do we have to start letting people go because of the rate of inflation at the minute? We are struggling to pay the rates. So a 1.9% uplift, this is not about GP pay, this is about general practice funding, and I think that needs to be made really clear, and that's why GPs are up in arms about it.
Thanks, Naomi. Hilary?
Thank you. The report was really good, and the way you presented it, and it's great to see that you've mentioned a couple of times the equality health impact assessment and how that will be built into the mainstream plan. So thank you. Just a reminder to myself, I hope that that equally applies to the workforce as well, and how important care navigation is for patients. And I hope that as we're thinking about building up the care navigation resource, we pay attention to the diversity required of those roles. So that's just a reminder to mention that. And I think secondly, in terms of the R's, have I remembered rightly that advanced practice for nursing is now included in the R's? I may have dreamt it, but I know nationally we were really lobbying for that.
But the criteria changes quite regularly, but you can't, no GPs, no practice nurses, but it does include the advanced.
Great.
So it does include ANPs. It does include ANPs, but there's also a new role that's been mentioned, which is an extended nurse or an enhanced nurse. Yeah. Now, we don't actually know what that looks like yet or what that role would be. There's been no guidance that's been sent out on that, so people are awaiting more information.
That's really helpful to know. So I haven't dreamt it, which is also reassuring. But it's about working with our HEIs as well. So we're really investing in curriculums that develop more advanced practice. And then secondly, working with our HEIs as well. I suppose it's this how, as a board, we amplify the great careers that non-medical professionals can have in general practice. So it becomes a first destination of choice in the careers. Because if we get nurses, for example, I'm sure AHPs may apply to, I'm not sure. If we get them early at general practice, the research is telling us that there's less turnover, they tend to stay. In general practice. So if that's something about working with our HEIs as well, but something about more generally how we can amplify the benefits of general practice. Universities, local health education providers. I hope that was clear. I've got a bit interrupted there. Thank you.
John, let me just take Ruth and then Graham's comments, and I'll come back to you.
Thank you. I welcome the work that's been done, but what it just illustrates is the scale of challenge that we face in both stabilising primary care, but actually modernising, moving on and building the capacity we need to meet the sort of demand that we can expect in the future. So this is hugely important. I just had a couple of questions. one was around, I think the report says that we've met our targets on use of the NHS app, which is very empowering. If you're able to use technology, it does give you capability of things to do as a patient. But even though we've hit the targets, we're still running around 50% functionality. So I guess my question is, how ambitious are we going to be? I mean, we're in the middle of the pack. It's roughly what's happening nationally, but do we want to be more ambitious about using some of those functionalities? And the second one, and it's around reducing bureaucracy, and maybe I don't understand what it is, but there is a data line which talks about C2C onward referrals. I'm assuming this is consultant to consultant, I'm not quite sure, but they've doubled in the last 4 or 5 months. So I just wondered, 6.6% of all referrals. So I just wondered, should we be worried about this? And is it something we should pay attention to?
Thanks. Graham?
I'm hoping you're capturing all this, Jonathan. So the first thing I want to say is to Claire and Jonathan and all the people who work on this, thank you very much. Let's just take a contextual point here. Yeah, it is for the Department of Health and therefore the government of the day to determine what is in the GP contract, not us. Yeah, and what's really, really important is we maintain really great relationships with our GP practices and our primary care networks. And I thank you for everything that you're doing in that space, because whilst there is a dispute about the level of investment in primary care going on, there is still much that we can be doing. There is much that we can be doing to improve access, to actually improve the working lives of people working in these settings, and the experience that people have of those services. So I thank you for the plan, and let's make sure that we keep going with hope and optimism that the BMA and the government will find their way through the contractual dispute, and they will find their way through it soon. Jonathan, you didn't have the opportunity to listen to some of the questions that we were asked by the public earlier this morning, and whilst this is a more general point, I am going to attach it to a line within your paper about practice websites. And you tell us that practice websites, and we are reviewing with practices and giving them advice about what good looks like. Well, we had a very interesting debate at the beginning of the meeting about physician associates. And one of the things when we talk about what good looks like is absolutely making sure that the practice team is correctly identified and in no way, shape or form is the public misled. And I know you understand this, and I know it's been, topic of national news just recently, but through that process of reviewing what goods looks like, I think it would help if we could really communicate that again to all of our practices very clearly.
Good point, Graham. Jonathan?
Yeah, thank you. I'll start there. So you're right. So physician associates has been a very hot topic. There are relatively small numbers in general practice, but there are physician associates in general practice across Cheshire and Merseyside. There has been guidance that's come out from the BMA. There's been guidance from the Royal Colleges. So I think you're right, and that's a helpful prompt for us to make sure that we have something that we can put out to our practice to say this is what we would recommend. I've already had an email this morning from a PCN clinical director saying, can you clarify the guidance, because I don't quite understand what's going on and what I'm being advised to do as a PCN clinical director. So I think that would be very helpful. And yes, I think as much as we can get on our websites around that to avoid additional phone calls and hassle, the better. We really do need our GPs to understand who's doing what. So in terms of the contract, you're absolutely right, Graham, this is not us. Now, what I would say is that I think it's difficult for GPs who often don't understand the bigger system. So they just see ICB equals NHS England equals Department of Health. It's all the same thing to them. We are very clear that these are different things, and we have some work to do perhaps along that. What is encouraging is that I had a phone call a week or so ago from one of our local medical committee representatives who wanted to say, look, whatever happens with this vote, whatever happens this year, they understand that this is not us, they understand what we can do to improve things, and they want to continue to work with us. So they want to be very close with us in terms of what might happen this year and do things alongside us so that we are all aware of what's happening. So that's very, very encouraging. Yes, onward referrals, consultant-to-consultant referrals. We've just started tracking this. It's really difficult to get some of the data around the cutting bureaucracy in terms of what actually is going on. So we can identify the numbers of consultant-to-consultant referrals. We can't identify the number of ones where they're asking the GP to do that. And actually the issue at the moment is we perceive that they're asking GPs to do this work that they could do themselves. So in some respects, an increasing number of consultants is a good thing because it is cutting that bureaucracy. So if you go and see your consultant who says, I think you now need to see somebody else, it's better for you if they just do that referral rather than saying, I'm going to write to your GP and ask them to do it. So it's not necessarily a bad thing if that number is increasing. I hope that answers that question. And I would agree in terms of, yes, working with our health education institutes and continue to promote primary care as an excellent career opportunity, which it is. I still believe general practice is the best job in the world. I'm not sure how many of my colleagues agree with me, but it is. And it's a privilege to be able to meet people sometimes when they are most stressed, most vulnerable, to come alongside them and to make a difference for them in their lives. It's an amazing thing. And so we need to encourage people to consider this as a career going forwards. Thank you.
Thanks, Jonathan. Let me just bring in Joe and then Claire.
Just a sort of it's a prosaic question, maybe, Jonathan, but the cloud-based telephony, which is really great, I think, as an innovation, is there any sentiment analysis software associated with that? Because, as you say, lots of people calling in will be vulnerable, anxious, worried, concerned, etc. And, that software picks up frustration, escalation, confusion, crisis. And the reason I ask is we've adopted that now on mental health crisis lines, and two things. It helps stratify patients. Well, it helps, it's a good augment to the clinician. It doesn't replace the clinician, but it certainly helps stratify, and I think therefore gets patients to a better place more quickly. But I think our practitioners sort of really like it as well, because if they're thinking, I wonder if this person's tipping into crisis, if there's an additional indicator there, it sort of helps. I mean, it strikes me it would be a great way to build some additional capability into every single call.
I'm not aware that there is. I'm looking to John, who's also shaking his head. But
So I don't think as a core offer that from the suppliers that were on the framework, that's part of the deal. I think what I would say around the rollout, it's been moving a large number of practices in a short time. There's some heavy lifting involved there, and I think the next bit is using that technology to transform. I think that we need to look at that technology and how it could help.
Let me just bring in Sarah and then finally Claire.
Yeah, a couple of points. Firstly, on the cloud-based telephony, obviously it's not fixing the problems. As we've said, it doesn't get more people to answer the phone calls. But I spent some time going around different GP practices last summer, and one of the really interesting bits of feedback we had were from people who were using a practice where they were using cloud telephony and the callback function, and people were saying it was working, they were getting the call back, and how different that was from in other practices where they were saying, I'm skint, my credit on my phone's going to die, and I've got to sit on this phone waiting to get through. So it might not mean there's more people to answer your phone call, but at least you're not stressed with that on-hold music, wondering about your credit running out. And those sort of things really make a difference when people are struggling, and it hopefully will stop some people being kind of ruled out of getting access. We're not yet anecdotally seeing much improvement of patients' experiences, but we're hoping we'll have this survey and we'll be going out and asking people for their experiences. One little bit of glimmer is that some people are telling us that they're finding patches better than e-consult, that it just seems to make more sense and tinge around the houses less. So we'd like to see, we hope we'll have some good news coming back to you, but we also expect that it'll be showing some groups of the population that are still finding access really, really challenging, and that it's much easier. I could use different routes to try and get through to a GP practice. My experience is going to be different from somebody that might struggle with English as a second language or with a hearing issue, with lack of access to IT. So hopefully we'll be able to get some probably learning for ongoing future improvement rather than recognition we've got any quick fixes.
Thanks, Sarah. Claire?
Yeah, thank you. So I suppose in summary, I mean, the national plan came out last May, so we're sort of 9-10 months into it. I think really good progress has happened across all 9 places. In that time, we've invested a considerable amount of money. We've, in the R's scheme, but in other elements of the plan. I think the challenge as we move into the new financial year is to keep going and do better. And I think Joe's point about the cloud telephony, I think that's where we will work with Health Watch and others to try and be much more sophisticated in our sort of temperature checks in between the patient survey, because that's a bit of a do it once. What we want to do is do it more regularly and really target and ask the right questions of the population. It's going to be a difficult year. In terms of reporting nationally, they are introducing a smaller set of more meaningful metrics. So I think that will be helpful, and we can add our own alongside those if that's helpful to the board. So I think it's a big thank you to the team across all the places, and it's a big thank you to our primary care colleagues who have worked incredibly hard over the past 12 months, and well, always, really. Thank you.
Thanks, Claire. Echo those comments.
Just to pick up on Ruth's query around the NHS app as well. We know that it works well. And in truth, I do want us to be as ambitious as possible. What we worry a lot about are those who can't access and use the NHS app. We've heard already about constraints over capacity for people to answer the phone. So where we can drive as many as possible to use that digital offering and become self-sufficient, we do better protect the capacity for those that can't. They shouldn't be hanging on the line waiting to get through. So it's getting that offer right during times that we've heard of not expanding that workforce to work as smartly as possible to use the technology out there. So yes, I do want us to be more ambitious with that where we can be.
Thank you, Rowan. Thanks. And Jonathan, thank you again. I won't attempt to summarise again. There's a lot of detail and there are lots of responses. Thank you for that. Let's quickly move on to the establishment of the ICB Research and Innovation Committee. Here for approval. I guess we're just looking for comments and questions.
Yes, happy to take feedback from colleagues on that. Hi.
Hilary?
It's a great paper, fully support it. 2 quick comments. In terms of diversity, I'd really like to see a non-medical professional on there, an AHP or a nurse. I'm sure there's people out there who enjoy their clinical academic careers, or even if they don't, we could support that. And secondly, I think in terms of inclusion, we do have Chester University as well. I've just wondered whether we've paid any consideration to that. Thank you.
No, thank you for those. And I'm glad you've raised, because it's important that we are clear over this. We have expanded our committee, and I'm delighted that Fiona has joined that. Whilst medical, that very much brings the improvement interest into that. Bear in mind that beneath that, the steering group is bringing together every academic institution, does have representation from our AHPs within that. So the voice is there within it, feeding up through that executive committee to the main R&I committee. And we remain in consideration about our chair being non-executive as well. So that I'm hoping will further diversify us too. Thanks.
It's more sort of, I mean, nursing and midwifery and AHP, they're a huge workforce, and it's more about the leadership being visible at that top level. Thanks.
So I think there's a challenge there, isn't there, for the Executives Committee to be more inclusive of the other professions in the NHS. So will you give that consideration and come back to us on that?
Yes.
Yeah. Ruth?
I support that. I was concerned about one university being named, but I'm assured that all of the universities will, and all the professionals therefore will have access to this. Just a point on the roles and responsibility. It's called Research and Innovation, and I would just ask, not necessarily to change it now, but to go back and look and make sure that innovation is properly represented in the roles and responsibility. It reads more to me as if it's research focused, and I just ask the group to have another look at that.
Yeah, and there is no doubt whatsoever that it is the area of greatest opportunity for us, because research has traditionally been pretty well funded and supported through multiple routes that are out there already. What we've probably been less good at is pulling in innovation and really making it stick in the middle of this. In fact, at times we're often driven by innovation is being handed to us and we have to shoehorn it in, rather than in fact asking the question what innovation is demanded for our system, the population that we serve. So I'm very much cited that it is the biggest area of expansion within this. We are different. Many other systems have separated research from innovation, whereas I feel very strongly indeed that the skill sets are so significantly overlapping that they should be held together because one supports the other. So it is certainly the biggest area of expansion that I look forward to seeing happen in this space.
I'm trying to bring in Louise.
Thank you, Rowan, and I completely agree. I think having research and innovation bound together like that is going to be really powerful. I'd make an even stronger offer than I did to Claire for the Health Innovation Network presence in the room. There's real opportunity, I think, around alignment. The North West Coast HIN is leading nationally CVD programmes and health inequalities. And I think we are awash with opportunity if we can actually align our efforts around that. So very happy to be very closely involved. Thanks.
Thanks, Louise. So can I see, given those comments that we made today about the executive committee, and we need to consider other roles other than doctors in there, and strengthening the function, I think, of the committee in terms of its relationship to innovation. People happy to support this? Yep, let's get going on that then. Okay, shall we go to, I think it's the staff survey next, Chris?
Thank you, Chair. As members know, every organisation within the NHS is required to participate in the annual staff survey. That normally happens sort of between September and November of each year, and the results are generally published early March. So today I just wanted to share with you the results of the ICB staff survey, which is our second survey, but also provide a very, very high level overview of the staff engagement scores for the trusts across Cheshire and Merseyside. So in 2023, you'll see in the paper that the ICB had a response rate of over 75%, which I think it's an increase on the year before, but absolutely fantastic response, with 809 of our staff taking the opportunity to fill in the survey and tell us what it's really like to work in NHS Cheshire and Merseyside. The staff survey is structured around the 7 national People Promise themes, and you've got the detail of that in section 5.1. And members will note that whilst the increases were very, very small, we did see some improvements over the last year, and we did compare well with our peer group of ICBs across the country. But we do recognise that these results are not where we'd want them to be, and we've still got lots to do. Since the publication of the results on the 7th of March, we've been working hard with our Staff Engagement Forum to understand what the staff results or the survey results actually mean for our staff. And we've now held a number of team sessions, awareness sessions, really just socialising those results. And you'll see on page 494 of your pack the scale of the engagement that we've had since those results have been published. And I'm delighted that so many of our staff actually want to be involved in looking at what those staff survey results mean and how we can actually make the organisation much better. In section 5.6 of the paper, you'll see that our priority areas of work under each of the People Promise themes, and through our People Committee, we will report in terms of progress on that. What you have here is a very high-level summary and the data relating to the very specific questions. But to get the real detail of the survey and what it means for our staff, it's often necessary to cross-reference more than one question and to look at the issues that have been highlighted that perhaps haven't come through some of our formal processes. So things like our freedom to speak up processes or grievances or just informal mechanisms where staff can express concern. You'll also see in the report that we have what's called our RES data and our WDES data, so looking at from a race perspective and a disability perspective. And the RES data contains data that's based on the information that staff chose to share through the staff survey. That often is quite different to what we have in our electronic staff record, and we're really encouraging staff to update those records now on the back of the staff survey result. It is really clear that there are different experiences of our white, our BAME, our disabled and our able-bodied staff, and we're going to work really, really hard with our staff networks to develop appropriate plans and to really get beneath what that data is telling us. Because if it's not coming through formal mechanisms, there must be a reason for that, and we need to really understand it. So moving on to the ICS scores, so those for all of our trusts, we've just looked at, in this report, at our trust engagement scores. Across Cheshire and Mersey, nearly 34,000 of our staff chose to fill in the staff survey. And you'll note that in 12 of our trusts, they saw an improvement in their staff engagement score, with Liverpool, Heart and Chest again scoring the highest nationally. I think those of you here last year will recall that I also reported that. Across the 6 People Promise themes reported, Cheshire and Mersey as a system saw an improvement across every theme. And again, Liverpool, Heart and Chest scored highest nationally across all themes compared with their national peer group. And we've got lots to learn from the organisation. We've got mechanisms now to really share that. Each of our trusts will now be developing their own individual staff survey action plans. They're going through to trust boards, they're going through people committees, they're working with their colleagues and trade unions. But the initial review showed that the areas where we saw most improvement this year was, and I think quite surprisingly, satisfaction with level of pay, which was up by 7.28%. Having had a really positive appraisal, which was up by 7.3%, that was one of our areas last year that we said we really needed to focus on across Cheshire and Mersey. That there are enough staff to do my job properly, which was up by almost 6%. My organisation is committed to helping me balance my home and my work life. And finally, the recommending the organisation as a good place to work. But I think it's really important, isn't it, that the staff survey is just one indicator and on one point in time about how our staff feel. And I think we've heard a number of times today that the pressures that our staff are facing really impacts in terms of staff morale, their ability to come to work and do a really good job, but also to balance the complex lives that our staff have as well. And so it is really important that we develop a number of mechanisms where we can keep going out, testing with staff what it's like to work here, what's it like to work with our trusts, how we work in partnership across organisations. Because unless we do, we'll never get a situation where actually Cheshire and Mersey is a place where staff want to come and work. Most importantly, that they feel safe, that they feel valued, and that they can actually give their absolute best, and that will be recognised and rewarded. Thank you.
Thanks, Chris. Any questions or comments for Chris on this paper? No? Okay.
Yeah, I think, well, Chris and I have probably spoken about this, and it is tying it together. And I'm talking about our own staff, not the sort of system staff, that we still have to work on more appraisals being taken, more well-being conversations, because then you've also got lack of local listening mechanisms, which isn't a freedom to speak up, I assume. It's sort of building that whole, isn't it, whole circle.
Yeah, so every one of our places and corporate teams now have got staff engagement forums. They all come together to form the organisation staff engagement forum. So we're really confident now that they're really engaged with this. We've done a number of presentations and team sessions over the past 3 weeks where staff have gone in and said, what does it mean for us, this result? So we'll have not just one overarching organisational plan on this, but every one of our places will have a plan. We'll look at where are those themes. We had a session earlier this week with Claire's team where they looked at what was the result, what did it mean, why people answered the way that they had, in a very safe environment. But hopefully we'll take that forward. But we have now got quite a robust mechanism of staff engagement.
Thank you.
Thank you, Chris. Amy?
Sorry, I seem to remember saying the same thing last year, just about the lack of general practice, and I think it's the whole of primary care. So how are we going to be able to get a similar feel for how staff are feeling in dentistry, optometry, pharmacy, and general practice? What can we do to kind of bridge that gap?
I can respond. I can see Claire's already pressed her button.
So I can't answer for dentistry, optometry and pharmacy, but we're about to sign an MOU which will basically launch the staff survey for general practice staff. We spoke, Jonathan and I and Chris Lees were on a call with the LMCs last night, and it's a meeting we have every month with all of the LMCs. Part of that conversation was to share with them, as we'd had the conversation with Place, that we're going to launch the general practice staff survey this year. We have previously we haven't done it previously, partly because of timing and capacity, but I think we all recognise how important it is. It's very much promoted by Claire Fuller, the National Director, and obviously fits with wider conversations around general practice support and resources. So watch this space. So coming to a PCN in a practice near you in the next few weeks and months. So once we've got that, we'll report that through System Primary Care Committee and the Primary Care Workforce Group and bring that back to board.
That's great.
Thank you. Just a couple of comments from me. One is it's really good to see improvement both at the ICS level and within the ICB organisation itself. That said, when you look at some of the scores, and I'll pick, we are recognised and rewarded, or we're always learning, or we have a voice. None of those scores are over 7. That means 30% of the workforce doesn't feel that way, and they're really significant proportions. And given what we also know, that there is hugely strong evidence to say that the staff survey is a strong leading indicator of success into the future, we cannot not pay attention to these issues. I know in trusts, both through CMAST and through the collaborative, this is high on the agendas of boards, and I know there's extraneous factors that influence this as well. That's beyond the remit of boards. I think, tell me if I'm wrong, I don't think any of us are satisfied with those results, and we know we'll continue to do whatever it is that we need to do within our control to get things better. Okay, we're happy to move on, Chris. It's over to Fiona on building continuous learning and improvement culture, a hugely important topic for us.
Thank you, Chair. Hopefully you can see from the paper today the really high level of ambition that Raj and I are hoping that the board is going to endorse today, and also a real positivity. I think this is a really good positive thing for us to be doing when on the back there's been a lot of difficult, challenging conversations this morning. So I'm really happy to be able to be bringing this paper at this time. I was given the task of outlining our approach to improvement a few months ago, and it felt quite daunting, to be honest. But all the conversations that I've had since then have been nothing but positive. Everybody, it seems, there's real energy around this. People are really keen to embrace it. My own enthusiasm for this has increased. The more that I've read, the more conversations that I've had, my enthusiasm has grown, which is probably why there's, as a result, quite a lot in the paper today. But I'm going to assume that you've read it and that I will restrict myself to highlighting just a couple of things for you. Throughout the paper, I've tried to consider the dual role or dual considerations for us as a board. So we have our ICB as an organisation and our responsibilities to our staff, nearly 1,000 staff that we have. And then they are working in support of our role as an ICS system leader. Section 4 of the paper considers why do this, why improvement, why do it now? And it talks about some of the things that we have talked about this morning, our current challenges that really do lend themselves to a continuous improvement approach. And there are lots of new challenges that are coming along. I can remember all of the challenges we've talked about, urgent emergency care, the finances. I can remember sitting in this room 5 or 6 years ago, having the same conversation, and we haven't managed to make any progress. So we have to now do something different. And I think this is our mechanism to taking a different approach and being more successful. Both internally in our organisation, but also across the whole system. There's obviously a really strong financial and performance case for continuous improvement, but there are significant qualitative benefits as well. I think it's important that we remember it is possible to do things better and for them to cost less at the same time. There is significant benefit for our staff and all staff across the ICS, because we do hear that morale is low, and the last conversation on the staff survey, people not feeling that they have a voice or not having influence. I think this is a mechanism to give our staff, to empower our staff to make a difference, to feel that the work that they do does make a difference and can make a difference despite all of the challenges. But that will only work if we create an environment for them to work in that has really high psychological safety embedded in it. And that's a really important part of what I would like to do within this piece of work. I've referenced NHS Impact because it's a growing national approach, and it has and it will continue to influence our approach. But I think the real benefit for us is in having our own Cheshire and Merseyside ambition. Section 6 and 7 of the paper expand on this a little bit. The role of the ICB is absolutely critical, and what we've been thinking about is what is it about that only the ICB can do in this space? Because I do talk in the paper about all the amazing continuous improvement work that's already happening, but what is the ICB's role? And it's our whole system approach, our whole system responsibility that makes us uniquely and ideally placed to take a lead role and set the ambition for Cheshire and Merseyside in this area. We can leverage our position, our power to influence, our power to convene the system, to bring people together behind and collaborate behind this shared agenda. We've got tools that as one system we can use, our data, our whole system data, our clinical constitution, our strategies that are whole system strategies can help us to build momentum around the system approach to this. So our ambition is to absolutely for the ICB to lead continuous improvement in Cheshire and Merseyside, but also for that to be recognised locally, regionally and nationally. I've had the benefit of a number of conversations with the new National Clinical Director for improvement, and we are being recognised. He has asked me to go and present to the National Improvement Directors Forum on our approach to leading the system in improvement. So we are making progress. To do that, we need to make sure that improvement becomes everybody's business. And I will reiterate that if it becomes everybody's business, we have to create an environment that is psychologically safe for them to really push the boundaries of what they can achieve with this. So back to the top of the paper for what we're asking of the board to endorse that ambition, but also when we have our development session next month, that you stretch us and challenge us to go further. I'm obviously really enthusiastic about this, but we do need to recognise that there is a resource requirement, that this isn't an overnight fix. But despite that, we will go after some quick wins, which is why we've identified all-age continuing healthcare as the area we want to go at first in this, and hopefully the board will endorse that approach and endorse the approach to invest within our financial plans so that we can make this work. Thank you.
Thanks, Fiona. So I can take questions or comments. Ruth?
Well, first of all, this is really welcome. I think it sets us on a path. Clearly, there's more to develop in terms of the approach, but I think this is a strong start to the conversation. I think Don Berwick, who you'll know is a global guru on patient safety and quality, talks about joy at work. And I think it's really important that we give people space to speak up about what needs to improve, but in particular give them time to do it as well. So there is something that as you go to the next stage of developing this, you think about how do we free people up to have the headspace, the time to actually be able to do this, given the pressure on delivering the frontline service. But this is the way forward in terms of improving and responding to some of the things in the staff survey. So strongly welcome it. The other point I wanted to make was in the language, there's 1 or 2 paragraphs, it talks about saving money. And I think it's really important. It's about improving patient outcome and experience as well as doing it more efficiently. So being clear, this isn't just about driven by efficiencies. It's also about can we do better with the money that we have. And then finally, in the design of the next phase, I'd like to see a strong emphasis on co-production with service users. It's absolutely clear that solutions are not the gift of just professionals, and service users will have many insights that will help frame what's important and how to change things. Those are all for the next stage, but in terms of what you're asking today, I think it's a really helpful first step, and thank you.
So any other questions or comments? Joe?
Thank you. I'm very supportive of this. I think the content's great. Fiona mentioned the phrase psychological safety twice. I think it's the missing component in this. These things have been done many times, and you usually see great improvements and then they plateau off. And that's because the people who want to do it. But the people who are more hesitant about the risk of undertaking change, and that's most of our staff actually, need to feel psychologically safe to engage. So it's a brilliant start, and Fiona and I have chatted. I think there's a strong sense of, this is phase 1. Phase 2 needs to address some of the things Ruth talked about, but how do we get staff to really want to pull this stuff rather than feel it's been done to them?
Thanks, Joe. Naomi?
Just say I'm absolutely in support of this. I think Ruth already made a couple of the points I wanted to, and far more eloquently than I would. But just to add, I think, a lot of times when we have things come to board, my question is always, well, what next? And what now? And how do we then develop that? Or how do we, and I think this gives space and resource into us being able to ask those questions and to being able to then act on. One of the examples that came to mind was when we had that amazing initiative, I think it was in Knowsley, and we had a really moving video regarding patients who were given fuel vouchers and the impact that made on their lives. That was really innovative. It made a massive social and clinical impact on those people. So what next, and how do we then? And I think that actually this will allow us to be able to build on these innovative projects.
Thanks, Naomi. Tony?
Yeah, thanks. Just pick up on Ruth and Joe's points. Ruth, first of all, said this is not necessarily about the money. This is about making positive changes and engaging people better, and that's absolutely correct. It motivates people to do it. And the point Joe made there about we can fall into temporary improvements. I think what this should be aiming to do is bring about a more resilient system for us rather than any small temporary short-term gains. So we're looking for a much longer-term return on the investment here. Thank you.
Thanks. I'm going to say a couple of comments, but I'm going to ask Mark and Deborah just to give us a viewpoint from place. How are you hearing this? And especially, Deborah, I think you said in your presentation your ambition was to identify good stuff and then get it, spread across. Just a couple of comments from me, and we'll ask Graham to sum up at the end. We're a new organisation, and my belief is if the ICB both doesn't recognise the importance of continuous improvement and is capable of doing it, it will get in the way of the great work that's happening in many organisations, because we just don't understand it and therefore will trivialise or minimise it. So there's a counterfactual argument to say that we should do it. But on top of that, the evidence-based Don Berwick onwards just says that if you are a healthcare organisation, I think you can apply this to care, if you do not have an approach that's akin to continuous improvement, the best you'll get is sporadic perhaps unsustainable change. It's continuous improvement that makes a difference in the complex world of health and care. So hugely supportive of this. I was going to come back to Deb, so
Sorry, I mean, I think from you know, in terms of managing the teams at place, I think one of the things that we're focusing on is the legacy from the CCG and the way in which we want our teams to work differently around continuous improvement. So there is a culture and development piece that we need to think about through place. And that's really important because we see examples of maybe just repeating the same things rather than thinking more creatively and transformatively about what we can do with the resources that we've had, but also about the talent that we have in our ICB. So I think we actually absolutely support the approach. So Mark, did you want to?
Yeah, I completely agree with that, and I think I suppose it's so important to us in the landscape and the context we've talked about all morning about using the resources we've got more effectively. And we know Deb's point that we see examples every day of where there are missed opportunities, there are things that we could do better, and we desperately need to, in a landscape, as we've said, of not having extra resources in that sense and needing to make more of what we have, and moving that sort of cost to quality kind of example of moving it from that reactive to that proactive sort of scale really, and again making use of what we got. Again, could sit here for half an hour talking about the the expenditure that we incur from a place perspective, which if we could have done something different at earlier parts in that pathway. And I think the improvement cycle is very much about identifying those opportunities, and then again at place level working with system partners to understand, well, what could we do different in a collective sense. So really welcome it and look forward to embedding it within our teams in the months and years to come.
Thank you.
Graham. Chair, thank you. I want to ask the question that you asked Mark and Deb. I just want to build on what Deb said, basically. We've done too many transactional things in the past. Despite the fact we've done too many transactional things in the past, within our place teams, we have about 170 members of staff who have the word transformation written somewhere in their job description. And we need to give them the kind of the methodology, the training, the concept, and actually the support to work in that transformational space. You've heard this is about the culture and a cultural shift. This is about a long-term approach to the way we want to work. But this is also about equipping our staff with a set of skills that every one of our NHS providers would also recognise. So it would be very easy for one of our staff to go and get a job in one of our NHS providers because they've got a skill set. And in turn, it will be a kind of blueprint which will help us to encourage staff from our providers to come in and work within the ICB as well. So I think this is all positive. I think it's really important that we've set this out. However, Chair, before we approve this, I just have to be a bit technically detailed, and I would ask that the fourth bullet in the board is asked to is actually rewritten to reflect what paragraph 12.4 says, because we changed paragraph 12.4, but because our continuous improvement culture isn't embedded, we didn't go back and check that we should have changed that bullet as well.
Okay.
So subject to bullet 4 reading as paragraph 12.4 in the paper, I'd like that change made before the board adopts it, please.
Okay. Before we just approve this, I need to bring in Neil.
Yeah, thank you, Chair. I fully support this. It's crucial that we do this. I suppose my only question is in saying that, and I don't want to put a caveat on this, but £500,000 is, how are we going to fund that? And should this be considered as part of our forward plans and not taken in isolation of a bigger picture? So it's the concern about we need to get on and do it, but how are we going to fund it?
That's the point I've just made, Chair.
Yeah, it is. Neil, we'll come back to that in a second. So there was a number of endorsements and approvals including in this paper. For us to summarise it is, firstly, seeking the board's approval for having a continuous improvement approach We aim to be part of the DNA of the organisation, embedded in everybody's job. Yep. Having it, led from the board onwards to emphasise the priorities. Yeah, we've articulated a place in which it could land first. All age continuing healthcare, that was another one. And then should we go to the money? And let's have a look at 12.4. And it says, once we've prioritised and aligned our existing resources into improvement and considered new investment through the corporate budget setting process, we anticipate an investment of circa 500k is required to create this core team. This will fund the senior leadership required, as well as OD practitioners and quality improvement expertise. So that is saying we've got work to do to identify securely this funding.
And it cannot be out with our normal processes.
Yes. Claire?
Yeah, it was just, we were not asking the board to approve this investment today.
Clear.
So
That's clear.
Yeah.
However, what we're hearing, I'll say this one, is that we believe it's a high priority. Okay, should we move on? Emergency preparedness, Anthony.
Thank you, Chairman. Just to point out, this report has already been subject to quite a bit of discussion at the Quality and Performance Committee. However, actually, it's one of the core standards that it also comes direct to board. Paper's pretty self-explanatory, really, in setting out the statutory duties of a Category 1 responder under the Civil Contingency Act, of which the ICB is one, as are all of the hospitals. We have to produce an annual assurance statement on that. And just to point out that NHS England hold the rings on that process each year. And during this year, they changed the process for the North West, which moved from one of self-assessment by the responder to one of a panel review process. It was a process that was adopted early in the West Midlands last year, and North West was next on the schedule for rollout. The precise detail of the evidence that was going to be required against each of the standards came really late in the process, and it had quite a marked effect on the scoring, as indeed was the case in West Midlands, and certainly NHS England have accepted that a more formal debrief needs to be undertaken ahead of any further rollout. What I'd stress, therefore, is that any comparable scoring of this one with last year's cannot be made. And much more importantly, it shouldn't be taken as a reflection of any organisation's ability to respond to an emergency situation. Indeed, if you look at what Cheshire and Mersey organisations have responded to over the course of this year with fire, flood, multiple major incidents, road traffic accidents, they've all been responded to extremely competently, as well as the wide-ranging, more planned impacts of industrial action that have been a key feature over the past year. I'm not trying to downplay the importance of this. That evidence is really important, and the LHRP, the Local Health Resilience Partnership, have recognised that they've set up a subgroup with all providers involved in that, which is there importantly to ensure that preparedness for the assurance process is there, that communication on standards is released as soon as possible, and we expect to move to a further higher degree of compliance moving forward. Turning specifically to the ICB's own scoring, that the figure there is 40%, is lower than last year, but as I say, no direct comparison should be made. There is an action plan against each and every one of the standards that you can see as the appendix on the back, and we will use Quality and Performance Committee to monitor progress against that action plan during the year. As indeed any debriefs from incidences will flow through that committee routinely. Just as finality, I've put for information all the various scores from all the Cat 1 responders of the system, because as we chair the LHRP, it is part of our responsibility to understand how other organisations are faring, but we have got assurance, as I'm sure some of those Cat 1 responders in the room will vouch to. Each of those organisations has an action plan. Each of those organisations is involved in the processes that we're setting up over the course of this year to improve it. And we all have a high degree of confidence that we will move up further through these compliance ratings over the course of the year. accepting, of course, new standards will come out and evidential requirements may change during the year.
Thanks, Anthony. Board's here to provide, the papers are here to provide assurance to the board on appropriate progress, both for the ICB and the system. Any questions or comments before? Ruth?
Just to underpin the importance of us continuing to make progress on this. We've been through major threats, not just fire and flooding, but pandemics. There's a huge amount to learn about how we collaborate. And so I think the area of cooperation with the Category 1 responders is important, not just within the NHS, but how we strengthen the partnership working going forward. It's never perfect. So there's quite a few areas there where I look forward to making sure that we continue to drive forward the strength of relationships and partnership working. Question, do we take feedback from our partners outside the NHS to inform our plans going forward?
Yeah, so for instance, the Local Health Resilience Partnership, which I co-chair with two of the public health directors, one from Cheshire and Merseyside, and has up to representation on it, is totally integral. The MRFs are on it as well, so police, fire, etc. So it is a complete partnership setup. And the point about that, you know, that common understanding, that common purpose and the learning from each other is critical to us. I think if I was being very critical, I would think that the process that's been run predominantly by NHSE in previous years has very much wore a regulatory hat rather than a responder hat. And therefore that's the bit that we're setting the course for this year.
Thank you. So we're comfortable to receive that assurance. We can see some of the improvement plans in there. And it comes back when, Anthony?
So the annual assurance process will be September next year,
okay.
With the outcome November, December time.
Thank you. Thank you. Rowan, shall we move into data into action?
Certainly. Thank you, Chair. I'd like to think that this piece forms almost the end of one of our golden threads that we've talked about today. We've almost, to encapsulate what I've heard, is we need to get far better at being a learning system. And in order to learn, we need to really understand what is going on. So I think the improvement part that's been discussed already is very much our approach to effecting change. But I think in order to reach that point, we need to turn the data that we have, and there are millions of data points out there that risk of themselves being of little value, into health intelligence. And it's the into part, the so what questions, because we are not here to commentate on how challenging things are, but to effect genuine change. And that's writ large through our clinical constitution already. That this very much needs to be the engine room of delivering that for our system. There are colleagues in this room, and I particularly thank Professor Rafferty for the work that's been done to create the real building blocks and foundations of this through COVID. But our ability to be a system that properly understands the challenges and issues, can synthesize meaningful solutions, and then through the work that Fiona leads, go about and effect that change, embed that change, learn from that change, is going to be one of the routes to our success ultimately. So this paper is specifically entitled Formalising the Data into Action programme, and there needs to be a number of sessions with our board to put very much more flesh on the bones of precisely what this delivers, almost in business units, and how that feeds back. But this is rather the launch of some of the governance now, and the start of us building what I believe needs to be a really significant brand for us. And by brand I mean something that is trusted to make a difference, that our communities come with us, and I don't doubt we'll touch on the really significant information governance that sits behind this being safe and sensible, the engagement with our communities and the co-production on the sorts of things we do. We mustn't forget what it's delivered already, and Naomi's already referenced it was data into action that allowed us to cross-reference those living in fuel poverty and deprivation with diagnoses of COPD and asthma that has seen hundreds of thousands of pounds delivered to those families that they were always entitled to. So this is the start of and the formalising of this journey, but a significant journey for us all to be on. I'm delighted that both Jim and Andrea have come to speak to some slides on this today. Thank you, Chair.
Thank you. Welcome, Jim. Andrea.
Thank you, and thanks to everyone here. Just to introduce ourselves first before we get through. Perhaps just to check how long we have for this, Raj. I know you're going to say like 2 minutes or something like that. Okay, thank you very much. Yeah, that'd be great. So I'm Jim Hughes. I work at Merseyside as strategic advisor on digital and data programs, and also for some of my time I work supporting John in the ICB across data programs, and this one most specifically. Andrea.
Hi everybody, I'm Andrea Asprey. I'm the Interim Programme Director for Data Interaction, and I'm also the Deputy Director of Strategy and Integration for Liverpool Place. So I'll crack on if that's okay. Thank you very much for the time to come and update you today. We'll just go through some slides and we'll try and do this as quickly as we can. We'll talk a little bit about the background and context of the programme. We'll move on to talk about our methodology and our approach and how we hope to drive the programme forward over the next couple of years or so. So I'm assuming this will take us to the next slide. It does. So this schematic here just gives a little brief summary as to the background of data interaction. And within our scope, anything that pertains to our big linked data set, our secure data environment, comes under the scope of data interaction. And there's a huge amount of legacy work that already sits behind this, as Rowan has already alluded to, the CIPHER programme, which of course was significant during the pandemic, the System P programme, which Professor Rafferty led, and has a lot of legacy work around our segmentation thinking, which we'll talk about in just a couple of minutes. Also mental health research, the Northwest Secure Data Environment, and a huge amount of academic and research input from the University of Liverpool as well. So in the centre here, we can see that our challenge really is to pull together a huge amount of disparate projects. There are over 50 already within the scope of this. And it's our role now to try and coordinate and align all of those assets so that we can really optimise them as we move forward. So for example, if we had a new data set that came online, what we'd really need to do is make sure that we had all the technical expertise that could help manipulate that data and apply it, that we also had the data and analytical skills to be able to interpret and manipulate those things. And really importantly, we need to make sure we've got transformational capacity, so all of those different teams across the ICS who have a role in making change on the ground, we need to make sure that we're working in partnership with those teams. And then also potentially when we're talking about huge, large-scale change, we must ensure that the contractual and financial levers are also in place to enable us to really affect that change at scale. So that's the scope of the programme. In terms of our system partners, I won't list them all, of course, you can see them in front of you, but a couple of things to sort of draw out. I'd say that our CHAMPS network, the public health, is a huge influence there in terms of our thinking. It's really about us bringing together all of our partners, particularly across from different provider organisations and local authorities, really important. And particularly also, I think the voluntary sector is going to be hugely important to us in our prevention approach in terms of getting upstream of some of the big challenges and particularly reaching out to those parts of our population who don't benefit from health and care services which are delivered in quite a routine way. So a really important partnership. In terms of our governance here, a group which is very much the engine room of where we bring all of these different projects together and try and coordinate and align them as best as possible. And we've got 4 subgroups now, which are almost all established, the latter being the multi-professional steering group, which will be convened from next month. Lots of work, which really is really important in terms of the information governance, in terms of the technical work, and also, crucially, the patient and public engagement. We've got a real task to make sure that we link into this board and all of the other groups and committees across the ICS in order to make this land most effectively. Jim?
Yeah, so just in terms of the data that we're bringing together, it is the data from that perhaps we knew about when those that were involved in the CIPHER programme and saw that in action, from the acute trust, from mental health community, importantly from our GPs, and some of the social care data, not all of it, and also the national data sets. And then we have a pipeline of other data that we can bring. And it was interesting to hear what you'd said earlier about the use of non-health data and the determinants of non-health data. And I think that's an important aspect for us to bring into this as we move forward. If we just think about the information governance, I absolutely will not go through an information governance slide in detail, but from a point of view of assurance, I think the important thing to note is that the work that goes behind this, and in particular, most recently achieved through the Confidentiality Advisory Group in the Section 251, is national assurance that says the approach that we are taking is assured in terms of the work that we've done with patients and data controllers, and that we have a secure platform. So they're the important messages that we take from that. So we're going to talk now about the deliverables of the programme, particularly the risk stratification approach, where we can identify individuals. The important thing there is that we do that in a consistent way and a way that is scalable, so that if you decide as a board, this is what we do, then we find that that's repeatable, we reduce variation, and we achieve the outcome goals. Segmentation we'll talk about in some detail, also some work around establishing Population Health Academy for the competency and capability in our workforce in this area, and significant work that we've done around engaging the public and patients, and then a little bit around how we support our research and innovation agenda. I won't go again, not in detail, but in the top right, and just refer again to the programme that's been, the piece of work that's been to this board around the fuel poverty. I think you will all recall that presentation. It was very impactful. It's received a lot of national coverage because of its impact and how it was delivered. It is delivered because we're able to bring the assets together and because we're able to convert them into action. It's a really important example of how we can deliver our agenda. The most recent is that we're able, again, to operate consistently, to access the GP data, to re-identify it into secondary care so that our secondary care clinicians can see it, in order that we have a consistent way to deal with patient safety so that the individual patients aren't adversely affected through this. It's a significant piece of work, and if we weren't able to do this, it's a huge piece of work for each GP practice, it's a huge piece of work for each trust. So we're reducing the work involved, and we're standardizing an approach.
Thank you. So some of the legacy from System P is about how we take a population segmentation lens to our population. And this is an approach which has been nationally endorsed by a number of different bodies. And we're really keen to make some more progress in this area. We'll be embarking upon a big piece of work to look at all of the financial and activity analysis across our population segments, with a view to considering, the variation across different places and different neighbourhoods, and how we can really tap into that as an opportunity to reduce that variation. We know that there's a huge amount of duplication and fragmentation across different sectors and across different services within our places, and this will really help shine a light on how we can actually do something to improve those outcomes. It's very much about trying to take a preventative approach, about reducing the burden of disease, and to create a system which not only is much more sustainable from a whole health and care economy perspective, but actually demonstrably changes and improves outcomes for our patients and families. And the reason why I personally am a big fan of this is that it does put the lens and the frame on our population. It does look at those families, those households, as opposed to us thinking purely from a hospital perspective or a GP practice perspective. And I think that is a brilliant platform for us to challenge ourselves on the type of care that we currently deliver. So that is the work that we'll be doing, and we'll be taking a health economics approach to really look at those opportunities to try and reduce some of the unnecessary cost and complication within our system. Our Population Health Academy is something that we'll be looking to bring online in the first quarter of next year, and Professor Ashworth is really giving his leadership and support to this as well. There will be two sort of component parts, one of which is making sure that the data scientists and analysts have got the technical skills to be able to work with these new kind of data sets, which, as we've already alluded to, are vast and are quite a new opportunity for us. But as well as that, and probably more importantly to some extent, is that our transformational leads, our operational managers, clinicians and others also have the skills to be able to interpret and manipulate that data and then to demonstrably change the care and services that they deliver on the ground. So this is going to be a huge piece of work that we'll take forward this year. We'll be covering a number of key topics, but it'll be really that kind of segmentation, multifactorial lens that we'll be looking at our populations with.
So I'll just say something about the secure data environment. It's a national programme in order to support our aspirations around research and innovation, to provide data for academics and our NHS colleagues who are involved in research, and very much linked in that way to the ambitions of the ICB. And through which we have a new data sharing agreement, and that's where we have the national approval to use that data without explicit patient consent, which is a significant step for us to achieve in that work. There are already some use cases that have used the population health approach that are, if you like, at the starting blocks for Cheshire and Merseyside to really take a grip of this research agenda with our academic partners. The work that we've done around the secure data environment includes an awful lot of, a significant amount of patient engagement and involvement, user groups, deliberative events. We have an example there of the patient leaflet that's going out with this so that we can fully explain to the public and to our patients how data is used and how it is kept secure. In order to build that confidence and build that trust with those that we serve. And through this next year, there'll be awareness-raising events with the public in order to continue that work and to work particularly alongside our colleagues in the comms and engagement team at the ICB.
Thank you. So just to conclude, really, you've heard a little bit of a bite-sized piece of information from all of these different component parts of the Data into Action programme, which hopefully you can appreciate is quite significant in its size. And one of our next key steps is that we've got a session in early May to look at all of the big deliverables for each of these component areas and to map those out and ensure that we've got a really comprehensive plan to align each of those deliverables, really in order to ensure that we have optimum impact for the next 2 years and beyond. Of course, we'll be taking into account all of the drivers that are important to this board and to other groups and committees across the ICS to then create a really comprehensive plan to take us forward for this year and beyond. So, thank you.
Thank you.
Thanks, Andrew and Jim. Really well presented.
Just to wrap up, Chair, if I may, thank you both for coming. We live in a complex and very constrained system. The entire point of this is to simplify, is to give clarity, absolute direction on what we do, to bring in health economics as well now, to show not only what we do improves the outcomes of our patients, but makes the best use of the resources that we have, and it becomes an absolute bedrock that runs through everything that we do as a system, as a learning system, as a result of this being pulled close into the heart of Cheshire and Merseyside. Thanks very much.
Thanks, Rowan. Any questions or comments? Ruth? Naomi?
Brilliant programme, hugely supportive of data sharing in secure environments. That's my opening comment. You've mentioned public trust is key in this whole endeavour. So I think we need to be clear, how would we know we're building trust in that? You're obviously doing a lot of work in engagement, informing and so on, but being clear that you're making progress and you have got maintained public trust in this process is going to be key going forward. because this is a governance question, are we satisfied with the governance? I have delved into the sub-papers that are embedded into the actual paper, and I just want to pick out 3 things. PPIE, could I ask that you have a look at the governance of the PPIE group? Because it's mainly professionals, it's the Civic Data Cooperative that seems to be running that group with 1 or 2 other people. And I wasn't clear there were any public or patient representatives in the group itself. I know you're doing lots of work external, but you know, if this is a research program, you would have public and patient representatives in the governance of the program. So I think it would help that group to be able, and the whole program, to have those voices helping to shape questions, helping to shape interpretation. So I wasn't clear that we had PPIE strongly in the governance itself, although it's being addressed clearly by all the work that you're doing. You mentioned that you might want to bring other types of health data in, such as housing and homelessness and so on. I know you've got social care in the multi-professional group, but if you're going to bring in other types of data sets, we need to think about other types of professionals that need to be part of that, so I need to flag that. And then on the other one, the third one I looked at, data asset and access, it refers a lot to COVID-19 requirements. So I didn't know if that was an old paper or whether there was, what the relevance of that one was. Not to go into detail today, but the main point I wanted to make was, are we really embedding patient-public involvement and engagement in the governance itself?
Okay. I can answer very briefly on the public-patient engagement. So the terms of reference that are within the overall terms of reference were being developed as the paper was written. Since we have done a lot of the deliberative events and we've spoken a lot with the public, we have a whole host of people from the public who are willing to join that group and support our overall governance. And that will be a key part of that public-patient group as you described, as you've described, Ruth. I can't remember questions 2 and 3, but I think if that was the key, the professionals, yes, we agreed. So we're speaking with the other professionals within local authorities around housing and how we bring them in as appropriate into the multi-professional groups. So that is being addressed. So thanks for raising it, Ruth.
Thanks, Jim. Naomi?
It kind of follows a similar theme, really. I don't know if you're aware, but there's a company called Timu who are currently offering people £50 cash for their data on their mobile phones. It's a lucrative market. Data is, you know, it's like the utmost commodity in this day and age. So I think there is a public perception that any data, you know, being saved, being used, could potentially has value. So I think you've already addressed some of the concerns I had initially regarding you know, public engagement, but I think my main question is, can patients opt out of having their data used?
Yes, within the patient leaflet and within the information that we sent out, but to data controllers as well, the opt-outs are laid very clearly, and we've also provided a dedicated phone line so that if people do want to opt out, they can discuss those options and opt out. This is so. Although we're saying we're using data, we can conduct research without explicit consent. At the same time, we are offering and making clear and articulating the option to opt out from data usage. Absolutely.
Thanks, Jim. Ian?
Thank you, and thank you, Angie and Jim, for the work going on with it all. It was just a highlight, really. It's great that we've got Louise here as well, because the Innovation Agency have been supporting us with that academy that we're trying to develop. So we think that's a really fundamental thing we need to put in place, and links into the previous agenda item on improvement. It's also to say about the partnership, it isn't to be replacing the joint strategic needs assessments that happen in local areas, which are vital. It's about trying to enhance and support any consistent ways we have these tools that we are able to produce through the intelligence platforms that we got, that could be all used in a systematic way in local areas. It was just really to, and we had most recently at the Shadow Board, we welcomed our regional colleagues and public health colleagues from the local knowledge and intelligence service, and informed our joint forward plan, all the big information, aggregated information, so we can align the big picture with what our tools we can to put things into action. So it's just to give some assurance about how that knits into the wider system. We do need to do some more work with the wider determinants, thinking about the housing conversations, thinking about over blue light services and police and fire and business sector like we did previously before, how this information can be used in the most impactful way. So just add a little bit on that, Chair.
Thank you. That's helpful. Any other comments? So primarily today, focusing in on governance, we need to hear learn about where does this report into? Is it
that transformation read across is vital, because that is one of the most powerful effector arms of change, is through our transformation group. So the read across there is, whilst it's written in there, we will make more explicit. But I also welcome that the board perceives the importance of this, that we continue to report here as well. Thank you.
So, are the board happy for this programme to report into strategy and transformation? I could put a caveat on it. Given the significance of the programme, I think we do need to see, perhaps through the committee, a direct report into this board at a frequency we can agree. It feels like 3 times a year something. Last one from me, which is it's about governance today. But in due course, we do need to understand the return on investment on this work, so the impact on some of our really knotty, important strategic goals ranging from patient experience to efficiency and effectiveness. And I know you've got some of that in chain. So, once again, thanks Andrea, Jim, really well presented. Hugely important topic to us.
Thank you.
Thank you.
Thank you. If I can go to the next agenda items, minutes of the previous meetings. Any? Claire?
Just one, please. Just on the finance update section, it's just missing the net risk that I reported at the last meeting, so I could just add that in. That would be great. Thank you.
Thank you. Subject to that, can we approve the minutes as being fair and accurate? Yeah, thank you. Board action log, you can see it there. I'm not going to make any comment on it unless anybody wants to give me an update or a correction. People happy to receive that? Yes. Closing remarks is another good meeting, lots of challenging things. Thank you for your time and attention as well.